Hello, my name is Laurel Stein, AFSP's Executive Vice President and Chief Policy Officer. On behalf of everyone at AFSP, I want to thank you for joining today and supporting AFSP's 2023 Virtual Advocacy Forum. AFSP's mission is to save lives and bring hope to those affected by suicide, and we cannot achieve that mission without the many voices of our advocates like you across the country. Thank you. The sessions shown were presented live to our in-person audience yesterday, and we are happy to be able to share them with you along with some remarks from several members of Congress and our national partner organizations. Throughout today's event, if you have any questions for AFSP's public policy team, please put them in the comment section and we will do our best to respond to everyone. Over the next 3 hours, you will learn about 3 key policy issues that AFSP is supporting as part of this year's Advocacy Forum: veteran suicide prevention, youth mental health and suicide prevention, and 988 and crisis services. You will hear from members of Congress, federal agency representatives, experts in the suicide prevention field, and some of our key national partners in this work. After the program concludes, we hope that you will use your voice as an advocate and contact your members of Congress through the AFSP Action Center in support of these policies. You can personalize each message to share a little bit about your connection to the cause. It is vital that your members of Congress hear from you and join us in fighting this leading cause of death. Finally, before we get started, I want to thank those members of Congress that have supported this event, including our keynote speaker, Congressman David Trone of Maryland, as well as Senator John Tester of Montana, Senator Chris Van Hollen of Maryland, Congressman Grace Napolitano of California, Congressman Don Beyer of Virginia, Congressman Mike Lawler of New York, Congressman Chris Stewart of Utah, and Congressman Seth Moulton of Massachusetts, who have all provided remarks to share with you. Now, to kick things off, we have remarks from AFSP's CEO, Mr. Bob Gebbia, followed by Dak Prescott of the Dallas Cowboys and founder of the Faith Fight Finish Foundation, and Solomon Thomas of the New York Jets and co-founder of the Defensive Line. AFSP has been proud to work with the Defensive Line and the Faith Fight Finish Foundation to advance legislation for 988 and youth suicide prevention nationwide. Following the remarks, you will hear from Congressman Don Beyer of Virginia and Congressman Chris Stewart of Utah.
Hi, I'm Bob Gebbia, CEO of the American Foundation for Suicide Prevention, and I want to welcome you to this year's Advocacy Forum. You know, advocacy is one of the important ways we can accomplish AFSP's mission of saving lives and bringing hope to those affected by suicide. We need your voices, and I'm so glad you're participating in this virtual part of our Advocacy Forum this year. There are 3 important priorities that we are bringing to Capitol Hill this year. 1 is support of our veterans. 2 is to support 988 and more investment in crisis services in our country. And 3rd, a focus on youth suicide prevention. These 3 areas are so critical, and it really is important we tell our legislators what they can do to help advance suicide prevention in these 3 important ways. We have a set of public policy priorities on our website. I hope you'll visit those. They will guide our prevention work and our advocacy work over the next 2 years, but these 3 are the ones we're bringing to Capitol Hill this year. I encourage you to contact your members of Congress and ask them to support legislation supporting veterans, crisis services, and youth suicide prevention. We can't do our work without you, so please visit the AFSP Action Center and lend your voice to support this important work. Thank you so much for what you're doing to save lives and prevent suicide. Thank you.
I'm Dak Prescott, quarterback for the Dallas Cowboys and founder of the Faith Fight Finish Foundation. One of the 4 pillars of my foundation is dedicated to mental health and suicide prevention after my brother passed away by suicide during COVID in 2020.
And I'm Solomon Thomas, defensive tackle for the New York Jets and co-founder of the defensive line. Our real mission is to prevent youth suicide, particularly for young people of color. We want to thank each of you for participating today in the American Foundation for Suicide Prevention's 14th Annual Advocacy Forum.
We're proud for our organizations to partner with AFSP throughout the year to advocate for legislation involving suicide prevention and mental health, including suicide prevention for veterans, youth, and youth adults, and support for the 988 Lifeline and crisis services.
We encourage you to join us in making an impact by visiting the AFSP Action Center today at afsp.org/Action Center and emailing your members of Congress by sharing your story and encouraging others to do the same. We can help save lives.
Hello, my name is Don Meyer, and I represent much of Northern Virginia, Arlington, Alexandria, Falls Church, Fairfax in the U.S. Congress. And I'm honored to address all of those part of the American Foundation for Suicide Prevention on your 14th Annual Advocacy Forum. You are the most important part of our democracy. You're the volunteers. You're the ones who educate us about what we need to do about suicide prevention. And we have a lot of competing interests here on the Hill. So many people come to see us every day. But the ones we pay the most attention to are the ones who actually show up in our office, especially if they're constituents. But anyone who shows up in our office gets a lot more attention than the people we never hear from. And really, I can't think of a more important topic than suicide prevention. When I first got here 8 years ago, I was, for whatever reason, keenly alert to it. I'd read that 2/3 of our gun deaths were suicides. But at that point, really the only people paying attention to it were as if it affected veterans. With John Katko, a Republican from upstate New York, he and I formed this bipartisan suicide prevention task force. John's since retired, so I get to chair it all by myself for the moment. And it's a really important issue as we try to educate our colleagues about all the forces and factors around people who take their own lives and what we can do about it. But you're the most important resource. And we've done a lot of really good things. We've worked on the 988 number, the replacing, the suicide prevention lifeline equivalent of 911. You're probably aware, I think the number was a 500,000 call surge last October after the 988 number went into effect. We stand up, I believe, 4 or 5 independent suicide prevention lifeline centers, so that if they call the local volunteer agency or part volunteer agency and they don't get a call, it rolls over right away to the centralized places dotted around the country. I believe, again, taking statistics from last year, that the time to reach a call dropped from something like 2 minutes to under 30 seconds. A dramatically important improvement for somebody that's in crisis. We worked for a number of years on our Barriers to Suicide Act, providing things like nets on bridges, giving state and local governments the tools and the resources they need to take away those proximate causes, opportunities for someone to die by suicide. And probably most importantly, what I really need your help on is the campaign to prevent suicide. We've got all these good things like the 988 number out there, but people don't know about them. Many, many people don't know about them. I put it in every speech, and in every speech there are people who go, oh, I didn't know that. So please, let your members of Congress know. By the way, if you don't get to meet with the senator, him or herself, or the member of Congress, him or herself, please don't be discouraged. Our staff members are vital to the way this place functions. I have a wonderful team, and I listen very carefully to what they say. I take 99.5% of their recommendations. So you don't need the elected official to get to the source. You're just being here makes an enormous difference. So I'm just really grateful for your efforts, for making the trip to Washington to be part of this Suicide Prevention Advocacy Day. And thank you. Our goal is to get that 47,000 deaths per year down to 40,000 and then 30,000, and someday make it, single digit. Every one of us, if we look hard enough, has been affected by someone in our family or a dear friend. And we want to make that ever less likely and let people enjoy the full range, the full capacity of all the years that we're given. So thank you for your efforts.
Hey everybody, Congressman Stewart here. 6,000 veterans commit suicide every year. More than 4,000 young Americans commit suicide every year. 40% of young Americans in this work, whether it was creating the 988 National Suicide Prevention Hotline number or the continued work that we're pressing forward with. I couldn't do any of this without you. What a great organization. So grateful for the friendship, the work that we're doing together. We've got more work to do. We'll keep working with you. Thank you so much.
Thank you, Congressman Beyer, Congressman Stewart, and thank you to Dak Prescott and Solomon Thomas, along with their organizations, for supporting this year's event. We will now transition to our first policy session focused on suicide prevention for the veterans and service member communities. We would like to thank Dr. Tamara Campbell, Executive Director of the U.S. Veterans Health Administration, Office of Mental Health and Suicide Prevention, and Rachel Mackey, Legislative Director, Human Services and Education, Veterans and Military Services at the National Association of Counties, for participating in this session. Opening things up, we have remarks from U.S. Senator Jon Tester of Montana.
This is Senator Jon Tester, and while I'm sorry I can't be with you in person, I am grateful for the opportunity to share a few words. I'd like to start by thanking the American Foundation for Suicide Prevention for putting on this important event. I'd especially like to recognize the mental health professionals with us today. You step up each and every day to support those in need, and we are grateful for all that you do. Suicide is a national public health crisis and is devastating families and communities across the country, especially in rural areas. And it is clear that we need an all-hands-on-deck approach to address this systemic issue. Coming together to raise awareness about the suicide epidemic is key to this effort. Equally important is our ability to connect more people with the life-saving services they need, including our nation's veterans. While serious on-the-ground efforts have been taking place to expand the access as a result of my Hannon Act, We got to keep breaking down the stigma surrounding mental health and delivering VA the tools and services to treat invisible wounds of war. And that is why, as chairman of the Senate Veterans Affairs Committee, I'm proud to be championing bipartisan efforts like the Not Just a Number Act. This bipartisan bill requires VA to take a closer look at the complex factors contributing to veteran suicide, helping us make more informed decisions on how we can better support the men and women who have served, and ultimately save more lives. Now, there's far more work to be done. The fact is, one person lost to suicide is one person too many. And know that together, we'll keep fighting to protect more folks from slipping through the cracks. Thank you.
Good morning, everyone. I am honored to be here today with you, and I do not take what I do lightly. I know this is a heavy lift for all of us, but I am here to bring you a message of hope. Starting at our highest level of government, we have the unity agenda. And that agenda is tackling the mental health crises, the opioid crises, as well as making sure that we support our veterans. I cannot think of a more honorable mission than the mission that I represent for VA. I am a veteran. My husband is a veteran. My father was a veteran. And so it's in my DNA that I do this work. In regards to suicide prevention, we embrace the full public health model. And we recognize, again, at the very highest level, that we need to be inclusive. And so March 16th, 2023, we updated our mission statement in VA. And that is to fulfill President Lincoln's promise to care for those who have served in our nation's military, their families, caregivers, and survivors. And so we want to include everyone. Make sure I can advance these slides. Here it is. There's nothing more important in VA than preventing veteran suicide. It is our top clinical priority because we know that one suicide is one too many. This is a very complex issue that we deal with, and so we want to put it in its context. We want to acknowledge that veteran suicide is a complex problem. It cannot be addressed through a single solution, and it cannot be addressed by VA alone or clinical interventions alone. So we are committed to the full public health approach that includes both community prevention and clinical interventions. And that is why your presence here today is critical. Suicide is preventable. Suicide prevention requires a public health approach, and everyone, I mean everyone, has a role to play. If you look at our numbers in terms of the veteran suicide deaths in 2020, there were 6,146 veterans who died by suicide. Again, one death from suicide is one too many. Each year through 2001 through 2020, age and sex-adjusted suicide rates for veterans exceeded those of non-veteran U.S. adults. And the difference in rate was greatest in 2017. In 2020, this differential fell to 57.3%. So we are trending downward. We are trending in the right direction. And that is because of all the support and collaboration we get from you in the audience. Again, a full public health approach. In terms of risk and protective factors, risk factors include prior suicide attempt, history of mental health issues, substance abuse issues, access to lethal means. We know that if we can tackle lethal means safety, we are going to be ahead of the game on this. A recent loss, legal or financial challenges. That's why it's critical with our partnership within VA with VBA, relationship issues, unemployment and homeless. We partner very closely with our National Homeless Program Office. Protective factors, access to mental health care. Access to mental health care is critical. Sense of connectedness. We know that across the globe, people who feel isolated are vulnerable and at higher risk. Problem-solving skills. How do you look at a problem, break it down so that it's not overwhelming? Sense of spirituality. Is there a purpose beyond us that we are serving? Mission or purpose in life, physical health, employment, social and emotional well-being. These are all protective factors. And so the goal is to minimize risk and boost protective factors. The public health strategy combines partnerships with communities to implement tailored local prevention plans while also focusing on evidence-based clinical strategies. And so our evidence-based approaches are scientifically informed, and we follow the clinical practice guidelines when we develop these treatments. VA is now working with 1,250 local community coalitions engaged in ending veteran suicide. These coalitions are established through our public health model, and this covers more than 10.8 million veterans. Suicide Prevention SP Now. The 5 priority areas of the SP Now plan are lethal means safety, which focuses on firearm safe storage, suicide prevention in at-risk medical populations. So we know these at-risk populations include oncology and chronic pain. So we have mental health providers through our integrated clinical programming, integrated throughout the traditional medical clinics like surgery, like pain and oncology, and we're moving beyond the primary care model. Outreach to and understanding of prior VHA users and making sure that we capture those individuals who may no longer be engaged in VA, understand why they're no longer engaged in VA, and bring them back into VA for service. Suicide prevention program enhancements, and we have wonderful media campaigns, one of which is Keep It Secure. Our community-based interventions overlap with our state and national interventions. We have the Governor's Challenge. We're really proud of the Governor's Challenge, which is a collaboration with VA and SAMHSA, where state policymakers partner with local leaders to implement a comprehensive suicide prevention plan. We have Together with Veterans, which is focused on veteran-to-veteran coalition. We know that veterans talking to other veterans build an automatic allegiance, alliance, and rapport that we cannot do alone without them. We have community engagement and partnership for suicide prevention, which is a VISN expansion. Our VISNs are our regional networks, and we focus on facilitating community coalitions and building for suicide prevention. And then we have certainly outreach and education that provides safe VHA facility partnership events through local suicide prevention coordinators. Focus priority across community-based interventions is a unifying model. So we identify service members, We work with our Veterans Experience Office to capture those veterans as quickly as we can who are coming off of active duty, because we know that first year off of active duty is a vulnerable year. And so if we can capture them coming right off active duty, get them into our system, we're going to save lives. We also want to make sure we engage with families and help them understand the signs to look for when their loved one is at risk. We promote connectedness and improve care transitions. Again, we know that veterans feeling isolated and distant are going to be vulnerable, and certainly lethal means safety and safety planning. I can't not emphasize lethal means safety enough because we know the number one modality or vehicle that people in general and veterans in particular use to complete suicide is a firearm. And our veterans have easy access to firearms. They know how to use firearms, and they think about firearms differently, right, than the rest of the community because their firearm protected them during war times. And so they have a personal connection with it. Just to, I got the 5-minute warning, so I'm going to try to speed it up here. Telehealth programming is critical. Just want to mention about our partnership with the Staff Sergeant Parker Gordon Fox, which is a grant program that aims to reduce veteran suicide. It's a 3-year community-based grant program where we award grants to those who are eligible to help us in this fight. In September 22, we awarded $52.5 million to 80 community-based organizations in 43 states, District of Columbia, Americas Samoa, and then March of 2023, prepared for the second round of the grant award by publishing the Notice of Funding Opportunity. I just want to mention also the crisis line, 988, then press 1. We have more veterans are reaching out to the Veterans Crisis Line than ever before. Just March of 2023, we had 88,092 messages to the hotline. There were 85,191 contacts through calls, chats, and text. So this is excellent. Ending homelessness, we know that this is a vulnerable time when veterans are homeless. We have announced our 2023 goals for preventing and ending veteran homelessness. The words homeless and veterans should never be in a sentence together. So we are planning to place at least 38,000 veterans experiencing homelessness into permanent housing. And I just want to flip to, we have a lot of resources here for you, links for you to take, utilize them. We have consultation teams within our suicide prevention programming, as well as our PTSD programming. So we are here for you. Please pick up the phone and call us directly if needed. We value and honor the partnership here, and we really appreciate you. Thank you so much.
Well, good morning, everybody. My name is Rachel Mackey. I am the Legislative Director for the National Association of Counties, or NACO. I just really want to say I'm so grateful for VA and our partnership with this department. It's so crucial to the work that we do to serve veterans. So it was such a pleasure and honor to hear from Dr. Campbell. So to get started, I am just going to share a little bit about counties. Let's see. Is it me or is it the thing? There we go. Awesome. So I'm guessing that many of you hail from a county, perhaps all of you. The vision of the National Association of Counties is simple. We believe that if you strengthen counties, you can strengthen America. We represent the 3,069 counties, parishes, and boroughs across the country. And that means the 3.6 million county employees, as well as the county residents and the county elected officials that serve them. So we have a very large membership, and through that, we are able to provide services, grant-funded research. We create, peer networking opportunities and peer exchange learning. We have conferences and events, but a big part of what we do is federal policy advocacy, and that's where I sit and what I'm here to talk to you about today. There are 3,069 counties, parishes, and boroughs across the country, and veterans live in most of them. And so it is really my privilege to be able to work with a team of county elected officials and county employees who are veterans and who serve veterans every day. And for those of you in the room who yourselves have served, or perhaps if you have loved ones who served, I cannot thank you enough for your service. Yes, thank you. So, counties might do more than you think. Maybe some of you know, maybe some of you don't. But we really matter for veterans in particular across a whole wide range of services that I'll quickly talk through before kind of diving into the CVSO Act, which is why I'm here. Mental and behavioral health, counties annually invest $100 billion if federal, state, and local dollars in community health systems, including behavioral health. We support or operate more than 750 behavioral health authorities across the country. Justice and public safety. Counties play a very significant role in our local jails. We invest funds in public safety, and we also invest in diversion programs, including things like veteran treatment courts. A lot of the familiar faces that we see cycle through the mental health system and the justice population are one and the same, and those may often be members of our veteran population as well. Homelessness, as Dr. Campbell mentioned, is a really important one, and counties do a whole lot with respect to homelessness in general, but also working together, partners together to get to functional zero for veterans populations. We may operate continuum of care programs. We might be involved in the administration of HUD-VASH benefits, which is the housing vouchers and wraparound services for our veterans. And we're always investing in affordable housing and other solutions. At NACO, we have a huge housing reform task force that's thinking about affordable housing. So this is really top of mind for counties as well. And then workforce development. We are involved in the administration of local workforce development boards. And that matters not just for connecting veterans to employment, but we employ veterans also. Actually, 7% of employed veterans work for local government, which is a much higher rate than the 1% of the general American population that counties employ. And then, of course, I think one of the most major ways, and perhaps like unknown ways, that counties serve veterans is by helping them access their service-connected benefits. So in 29 states, counties use local dollars to fund employees called County Veteran Service Officers, or CVSOs. If you've heard of the Veterans for Foreign Wars, the DAV, the American Legion, these are all VSOs, Veteran Service Officers. They're nonprofits. But there are municipal and local and county VSOs, as well as state VSOs, who work for their government and also help veterans access the benefits they earned through their military service. So digging a little bit deeper into the role of CVSOs, like I said, in 29 states, counties employ this workforce. It's small but mighty. They rely primarily on local dollars. So these are not federally funded offices. There might be a little bit of state money, depending on the state, to help pay for this workforce. But typically counties are using, our own revenue to support these positions. And, that's important because CVSOs, as well as, nonprofit VSOs, provide their services free of charge. So if you're ever watching TV and a commercial comes up advertising, paid services for veterans to access their benefits, I want to warn you not to utilize those services, because there are free employees, often at the county level, who can help vets access their benefits for free. And, that can be a really complicated process. I think it's no surprise to anyone that VA bureaucracy is pretty expansive, and it can be quite confusing for veterans to access their earned benefits, to file their claims correctly, to appeal those claims if they're rejected. And so CVSOs are often licensed and accredited and have partnerships with VA that allow them to access important data and really expedite those procedures and just make sure that people are filing correctly from the jump so that they can get their benefits as quickly as possible. They're very successful at what they do. They help generate more than $50 billion annually in health, disability, and compensation claims for our former service members and their families. So this is a map of the 29 states with CVSOs and those without. Those without may have state VSOs that are their more publicly funded VSOs. And again, in all states, you'll usually find private nonprofit VSOs, and they often work in partnership with CVSOs as well. So why does access to your earned federal benefits matter for suicide prevention? I mean, we heard about this public health model, and it's so critical. And I'm so glad that Dr. Campbell mentioned a couple of key factors that I think CVSOs can really help address. Because while we are not mental health professionals by any means, CVSOs can really help support those upstream protective factors that Dr. Campbell was talking about to ensure that our former service members are not committing suicide. So in 2021, our federal partners created sort of a whole of government report about reducing military and veteran suicide. And it had 5 sort of major priority buckets. And CVSOs, I think, fit in especially into 2 of those buckets. The first one is increasing the access to and delivery of effective care for veterans. So CVSOs can, if properly trained, perform risk screenings. They can make referrals to community providers. So even though, their primary job is to help vets access their earned benefits, CVSOs are on the ground working with members of the community. They have relationships with community partners, with nonprofits, with behavioral health authorities, and they can connect veterans to those services as well. And then also, as we talked about, the importance of making sure that people are engaged with VHA, that is something that CVSOs do. They help people enroll in their veterans' health care. They help them access those benefits and get into the system. And that is so crucial because we do know that veterans who are in VA care have, wow, I'm really behind, have lower rates of suicide than those who are not. We also address upstream risk and protective factors by facilitating access to a wide range of economic supports, right? So it's those stabilizing factors that can keep people out of risk. And again, providing connection to local resources. So CVSOs are really important, but we face many challenges, primarily funding. Like I said, local dollars only go so far. Counties are limited in the ways that we can raise revenue because states mandate what we can and cannot do with respect to property and sales taxes and other revenue streams. Also, some of you may have heard and seen that huge toxic exposure legislation that was passed last year. That is great news for our vets. On the ground, though, we are seeing members say that they've seen, doubling, tripling of the claims that they're having to process due to those new benefits. Without additional money and staff support, that is really tough. And then we didn't talk a ton about military transition, but there's something called the deadly gap. That's that first 12 months out of service for a veteran. It is one of the most vulnerable moments in time. If CVSOs have the information they need, they can perform proactive outreach to new veterans to help them access their supports and services. But if we don't know they're coming to our communities, it can be very hard, especially because the newer generation of veterans is less likely to self-identify. And those brick and mortar sort of community centers like the American Legion, the hall you used to be able to go and hang out at, those aren't as common anymore. So it's much harder to find veterans in our community and get them the services they need. So the Commitment to Veteran Support and Outreach Act helps us, I think, address those first two buckets, basically just by, authorizing competitive grants to states to strengthen or expand CVSOs. So that means money for additional employees, training, accreditation, just the other sorts of work that costs money that helps us build this workforce up and access, more veterans, help more veterans access the benefits they need. Importantly, the grants will have a priority for areas with high rates of calls to the Veterans Crisis Line, because we recognize that linkage between CVSOs and suicide prevention. So I know that you all have a one-pager. We have one as well that I'll link to, but it's such an important bipartisan legislation. I know Bill is going to walk you guys through it a little bit more. We have some additional policy priorities for serving veterans that I'll just pop on the screen here. Honestly, Dr. Campbell covered a lot of it, but we are trying to work with our federal partners to promote veteran mental health and prevent suicide, and we are so grateful for their partnership and for yours as well. So one final plug I will make. Last year, we launched something called Operation Greenlight for Veterans. It's a national campaign where counties are lighting their courthouses and other municipal infrastructure in green during Veterans Week. But this is not just a symbolic, pledge of support for veterans. We are using it as an opportunity to let them know that resources exist, including CVSOs, but all sorts of housing, employment, and mental health benefits as well. So counties are issuing press releases and doing media spots and really using this green light to get attention to the resources available to veterans at the county level. And they're passing resolutions about their support for veterans. So just wanted to put that bug down. If any of you work with your county partners and you want to encourage them to light it up in green, we've got plenty of resources around that as well. And we welcome other organizations, nonprofits, state partners to do the same. I've got some links here. I assume you guys will be receiving these slides, so please feel free to click around. And I am so more than happy to follow up with any of you. Please feel free to email me. I'm happy to engage further and answer any questions you may have. Thank you.
Well, hi, everyone. First, I just wanted to say, could we give it up one more time for Dr. Tamara Campbell and for Rachel Mackey? You both did great. So my name is Bill White. I am Senior Manager of Federal Policy here at the American Foundation for Suicide Prevention, and I cannot say how exciting it is to be with you all in person today. This has been wonderful. To start us off, I wanted to talk about an important bill, as Rachel touched on, the Commitment to Veterans Support and Outreach Act, or CVSO Act in short. But before we discuss the bill in detail, I wanted to touch on the importance of this issue. Suicide is tragically prevalent among America's veterans. Since the turn of the century, 4 times as many veterans have died by suicide than have been killed in military combat. And we know that veterans are 1.5 times more likely to die by suicide than their non-veteran peers, as Dr. Campbell touched on earlier. I want to pause on these statistics for a moment. These are sobering figures. The brave individuals who serve to protect our freedoms need our support. Just as they worked to defend our country, so too must we work to defend their mental health. Okay. And we know that 60% of veterans who died by suicide had not recently received VA care. We know that the healthcare services and benefits provided by the VA save lives and improve mental health outcomes for veterans. Yet VA enrollment is low. We can do better. That is where tribal and county veteran service officers come in. These veteran service officers, commonly referred to as CVSOs, are county or tribal employees officially accredited by the VA to assist in connecting service members, veterans, and their families with service-connected benefits. CVSOs provide a human face to programs, services, and benefit systems that can be difficult to navigate on one's own. They're available to answer any questions individuals may have, and they help to simplify the maze of applying for benefits and programs available to them. For this reason, CVSOs are often the main link to veterans' benefits and services. They serve as a vital community resource, helping countless veterans and their families. Every year, CVSOs successfully process more than $50 billion in public assistance for America's veterans and their families. CVSOs operate in 29 states nationwide with more than 1,700 accredited CVSOs working across the US. CVSOs not only help to raise awareness of which benefits and services are available and who may be eligible, but directly help with the application process, directly connecting veterans and their families with benefits and services. And here you can see a comprehensive map of states with accredited CVSOs, as Rachel touched on earlier. As we touched on earlier, a majority of veterans who die by suicide had not recently received VA care. We know that that care, including mental health care, plays an important role in suicide prevention and in fostering positive mental health outcomes. For that reason, the work done by CVSOs to increase enrollment in VA care is a direct and important part of the national effort to end suicide. The benefits and services to which CVSOs connect veterans are an important part of suicide prevention as well. CVSOs help to process disability claims, education benefits, job placements, housing loans, and more, all of which have a role to play in suicide prevention. As was mentioned earlier, suicide is complicated. It involves many factors. And by helping to improve each of these aspects of the lives of veterans and their families, CVSOs are directly helping to improve their life outcomes and protect against suicide. And with all of that said, this is the call to action. In the following slides, we'll discuss how you can help to advance legislation to support CVSOs. The legislation we're advocating for on veteran suicide prevention this year is the Commitment to Veteran Support and Outreach Act, commonly referred to as the CVSO Act. It's sponsored in the Senate by Senator Tammy Baldwin and by Senator Dan Sullivan, and in the House by Representative Mike Levin and Representative Kathy McMorris Rogers. This legislation authorizes new federal funding to create a new competitive federal grant program. This new program would award funds to states through a competitive grant process to support CVSOs. Despite the importance of the work done by CVSOs, there is currently no federal funding to directly support their work. That's why this bill is so important. This bill will authorize the first source of federal funding to directly support CVSOs. It's also important to note the difference between authorization and appropriation. When a bill authorizes funding to be spent, it is allowing up to that amount to be spent on that item. It doesn't directly appropriate that funding. Appropriation comes later during the federal budget process, and that's the time at which the exact dollar amount that is decided to be spent on the program in question. With that in mind, we've put together a quick cheat sheet for use in your congressional meetings. I know we've just thrown a lot of information at you. This palm card summarizes it quickly, providing you with the high notes at a glance. You have a copy of this palm card in your notes, and my hope is that it'll help guide you through your congressional meetings. But I want to run through the content here quickly as well. The talking points I would emphasize are, first, veterans that are at a high risk of suicide relative to their non-veteran peers. Second, tribal and county veteran service officers help connect veterans and their families with benefits and services that help prevent suicide. And third, no federal funding opportunities currently exist to directly support CVSOs. With those points in mind, our request for members of Congress and their staff is to support and co-sponsor the Commitment to Veteran Support and Outreach Act. This means not only voting for the bill, but considering signing on to put their name on the bill as a co-sponsor. I hope these points are helpful. And as always, if a staffer asks you questions about the bill that aren't addressed here, it is more than okay to say that you don't know. If you're asked a question that isn't addressed here, please refer the office in question to our email address at advocacy@afsp.org and let them know that we'll follow up with them soon with an answer to their question. With that, let's open it up to discussion. Thank you all again, and I am so excited to be with you all here in person.
A reminder that if you have questions, raise your hands in the air with your note cards, and one of our team will come gather those from you.
Hi there. Thank you so much for that presentation. If we are from a state that does not have CVSOs, how should we approach the discussion with our legislature?
That is an excellent question. So the bill would authorize funds for CVSOs, tribal VSOs, or similar local governmental entities. So in general, states still may able to draw down on those funds and support other sort of governmental VSOs. The distinction is just that the money wouldn't be able to go to a nonprofit VSO. It would have to go to a publicly funded VSO. So in all likelihood, those states probably wouldn't be as high of a priority potentially for those funds. But I think you can also just remind them that, you know, even if it's not their state, preventing suicide amongst veterans in any state is important. But they would potentially still be able to apply for those funds and you know, just funnel them to a different type of entity.
Yeah, I think that is exactly right. And the only item I would add too is that if this bill passes, it could also help to incentivize the creation of CVSO programs in states that don't currently have it. Just because a state doesn't currently have a CVSO program doesn't mean it wouldn't have it in the future.
Absolutely.
I just like to add, when you go in, to just be very confident, because where Congress is concerned with veterans, it's bipartisan. Like, both sides of the house are for veterans. And so just be very confident when you walk in there.
Okay, next question is, are there any statistics on average age of veteran suicides?
So in our last annual report, ages 18 to 34 is our big area, which is surprising because the age has gotten lower, right? I've been in this field for about 30 years, and the demographic of white male over 65 and over has also been a vulnerable group, and that still exists. But 18 to 34 in this last annual report is what we saw.
Thank you. On CVSOs, how dependent are they on local versus state versus federal funding? And what are the implications for poorer or rural areas?
Excellent question. So as we discussed, there is no federal money right now for CVSOs, even though they're helping veterans access federal benefits. There are some states that do have some appropriations that are sent down to the counties for their CVSOs, but by and large, it is local dollars. And you're exactly right. For counties that have lower levels of resources or are rural, that means that the reach just isn't nearly as far as it could be. You know, I'll talk to a CVSO who actually, you know, spans 3 different counties and spends the week driving hours between the counties because those counties don't have enough money to have their own full-time employee doing this work. So it really is a capacity issue, to be sure.
Thank you. Someone else has asked, if the legislative assistant that I meet, if they ask if there are CVSOs in their district, how do I answer that question?
You should let them know that we'll follow up with them after to confirm. If you know for certain that there are CVSOs in that state or district, please feel welcome to say so. But it is, again, completely okay to say that you don't know and to direct them to email advocacy@afsp.org. The only other item I would add is make sure to make a note of that in the Soapbox app that you have. And that'll let us know to follow up with that office to let them know.
There's also our partners. We work with a wonderful affiliate organization, the National Association of County Veteran Service Officers, and they have a Find a CVSO tool on their website. So folks can search, you know, by zip code or by county or by state, and, you know, by clicking on a map to try and identify if there is a CVSO nearby.
Who trains a CVSO? And since a CVSO is not a mental health career professional, what credentials do they have to earn the trust of a veteran in helping them?
Many CVSOs are trained actually by that affiliate organization I mentioned. They offer education and resources. There are different sort of levels of licensing and accreditation that any VSO can access by taking courses, and they work directly with VA, with the Veterans Benefit Administration, to receive the credentials that they need to offer competent services and access the data that they need on the VA side for the veteran. In terms of trust, I think the important thing to note is that almost all CVSOs are veterans themselves. So they themselves have served, and I think that breaks down a lot of the barriers with respect to trust because of that shared experience.
And if I may add, we really want people who are not mental health providers, because there are people still afraid, and there's still stigma, and also sometimes our language is too technical for them to understand initially. And so we need you to help bridge that patient to us. And so don't think I'm not a mental health provider, I don't know what to do. We need you. We need people who are not mental health providers to help.
And I think in particular, because getting your disability or compensation benefits or your GI Bill benefits, like that, there's not that same level of stigma there. So it can actually be a really good entry point to connect a veteran to other community providers, other resources, VHA status, whatever the case may be. So I think it actually fills a really important gap there.
Yeah. And if you need to get them over to us, we say that mental health is health.
Yes.
And so you can use that term also. Mental health is health.
Okay. The next question is about the transitioning time period. So it says, a major obstacle at a county level is identifying both active duty and active reserve guards that are transitioning back to civilian life. How can DoD and VA create access to a database so that these people can be welcomed home and county coalitions can connect them to resources and other benefits in the community?
Well, whoever asked that question, you have asked a really important question, and it's a nut we haven't quite cracked. Here at NACO, we are constantly engaging both with the Pentagon and with our wonderful partners at VA, as well as state DVAs, to figure out how we can better get access to information. I think it's important to recognize that privacy matters, and it is up to service members whether or not they want to opt into having their information shared on their transition form. It's colloquially referred to as a DD-214 form. One idea that's been shopped around is actually having people opt out rather than opt in to that information sharing, because sometimes it's more work to check a box than to uncheck a box, if that makes sense. So that's something that we've talked about with our federal partners, but that data sharing piece is really tough because there's so many components, and it can be tough to identify incoming veterans, because when you're separating, you might not know where you're headed. So maybe you'll just put the address of your parents or where your base is. So those transition programs that DoD has, like there's one called Skill Bridge, there's the Transition Assistance Program. I think that there can be better pathways and connections, even between local partners, to make the existence of CVSOs known to veterans who might be moving to a new community. But it is a real challenge. Like I said, those brick and mortar legions and VFW halls, they're just not as common anymore, and it can be really hard to do the outreach.
Yeah, we certainly work closely with Department of Defense through our interagency work and with the Domestic Policy Council, and trying to identify those veterans who are going to be coming off active duty. Everyone receives a screening. So every veteran coming off active duty will have a health screening. That includes questions about mental health, but again, whether you choose to check it or not will then result in whether we know who you are. So any leverage you can assist with in helping us identify those individuals will add to the success of what we're trying to do.
Thank you. Next question is, if CVSOs will lead to higher engagement with services and benefits, Are there any plans to then increase funding of those services, who we hope will see higher rates of usage through the help of the CVSOs?
Well, the way that VA benefits work is that they are generally funded regardless. So it's less around needing to up the level of support, although I mean, I think that could be great, if we're talking about monthly benefits that folks are receiving. But I will say that one area we would love to see increased funding is within the Veterans Benefits Administration, or VBA. They have employees too, and they have quite a significant backlog of claims. So I actually think that if we're talking about, increased resources, increasing them there for those claims and benefits to get processed more quickly is a more important need at this moment, just because there are a lot of folks just waiting to hear about whether or not, they qualify.
Yeah. So I'll add, certainly with the passing of the PACT Act, we knew early on that we were going to see a tremendous increase in claims, and that there would be some backlog initially. We have certainly worked to decrease that backlog. We've screened about 3.8 million for that PACT Act. That's the Toxic Exposure Act, involves toxic exposure. We've awarded about $1 billion at this point, dollars to veterans who qualify for compensation under that. We also have what's called the Compact. We like all letters of the alphabet. Compact Act, which allows a veteran in a suicide crisis to present anywhere free of charge for that single episode of care.
Yeah, and the only item I would add, I think Rachel and Dr. Campbell covered that perfectly. The only item I would add to is just, again, stressing the need for increased enrollment in VA services and increased utilization of these benefits. That really is a central problem in veteran suicide prevention. These services are available, and just making sure that veterans know about them and are applying for them.
We have a question about differences in risk. So are all veterans at risk for suicide, or are those with combat experience more or less at risk?
So that is an excellent, excellent question, and it's multifactorial. So as you know, as human beings, all of us have probably had some type of trauma, right? And it depends on the significance of that trauma. So if someone has had a level of trauma prior to coming into the military, right, they're going to be at risk. And then certainly the closer to the combat zone, depending on what their mission was, that increases the risk because that increases the trauma. And then if you add co-occurring illnesses like medical conditions, diabetes, chronic pain, substance use, that increases the vulnerability. So everyone, I would say everyone is at some level of risk. Not everyone is at the same level of risk, and not everyone is at a high level of risk. And that level of risk is fluid, right? It can change depending on a veteran's circumstances and situation. That's why employment is important. That's why homelessness is important and reducing that. That's why being connected to a community is critical, and making sure that our veterans feel welcomed wherever they are in this country, whoever they are in this country.
Do we have time for one more? This one says, Dr. Campbell mentioned a focus on inclusion in the recent vision. What is the VA's plan to provide culturally competent care as part of this plan?
So excellent question. And we are certainly working with our tribal health subject matter experts to make sure that we are providing culturally competent treatment to that demographic. American Indians, Alaskan Americans. There are, as I understand, about 500 plus tribes. And so we're going to try to figure it out for all of those 500 tribes, because each has a different culture that needs to be respected, and that we need to be able to provide the care, and not just Western medicine. What is it that is important for that group so that they can heal? We know that also our female veterans have often felt not included. That is the fastest growing demographic in VA, our women veterans. And so particularly within our domiciliary residential programs, we have several programs specific regarding substance use and PTSD for women. We make sure that the units are safe. So we have closed circuit TV monitoring on those units so that our female veterans can feel safe. And then with all of our training, we try to, and I think we're doing a fairly good job of making sure that all of our veterans are receiving equitable treatment. We learned that particularly with the treatment of buprenorphine in our SUD population, that Black male veterans were not getting the same type of buprenorphine treatment at the same rate. So we monitor that. We monitor that by region, and we review those reports in our health operations center calls so that we can make sure that all veterans are being treated equal, and that they're all getting the same quality of care within VA.
I think that's the last question, correct? Yes. Well, please join me in thanking Dr. Campbell, Rachel Mackey, and Bill for this very informative session. And while we are reminded of the sobering statistics, we are hopeful that when you go on the Hill on Tuesday in support of the Commitment to Veterans Support and Outreach Act, that members of Congress, their congressional staff, this will resonate, and we will get this legislation passed this year. So thank you so much. Thank you again to our experts here. Appreciate your time. Thank you, Bill, Dr. Campbell, and Rachel Mackey for that great session. A special thanks to Senator Tester for his remarks. Our second session today will focus on suicide prevention efforts for youth and young adults. Speakers for this session will include Brandon J. Johnson, Public Health Advisor for the Substance Abuse and Mental Health Services Administration, SAMHSA, and Kenneth Polzachuk, Senior Director from Congressional and Federal Relations and Education Policy Lead at the American Psychological Association, as well as opening remarks from U.S. Congressman Mike Lawler of New York.
Thank you to the American Foundation for Suicide Prevention for inviting me to speak at your advocacy forum today. As someone who has lost close friends and family members to suicide, the topic is very near and dear to my heart. Suicide is one of the leading causes of death in the United States, the second leading cause for those between the ages of 25 and 44, as well as among those between the ages of 15 and 24. Tragically, it is among this latter group, teens and young adults, that suicide is the highest. According to data from the National Alliance on Mental Illness, nearly 20% of high school students report serious thoughts of suicide, and 9% have made an attempt to take their own lives. There is no question that in America, especially among young Americans, we are facing a mental health crisis. It is important that we make sure those with mental health challenges receive the support they need. During my time in the State Assembly, I supported additional funding for mental health. I also helped prevent the closure of the Rockland Children's Psychiatric Center. Had this facility closed, there would have been no childhood psychiatric center in New York between Utica and the Bronx. We need additional treatment centers for those struggling with mental health challenges, not fewer. Whether it's combating substance use disorders, lowering suicide rates, or tackling mental health challenges, I'm going to keep working to ensure Americans with these challenges get the help they need. Thank you for your advocacy on this important and deeply pressing issue. I look forward to partnering with you to save lives, because we all know one life lost to suicide is one too many.
Hello, everyone. Good morning. How is everyone doing? That's good. Oh, that was a real good. Somebody in the back is really good. But that's great. I am truly honored to be here today to have this conversation. I appreciate the invite. Thank you to Bob and his team for having me here today. So I'm also sending greetings from our Assistant Secretary, Dr. Delphin Rittman, who cannot be here today. And so I am here in her absence. And so excited to have this conversation and to really engage discussion on this topic as well. So really excited to get this moving. So let's move forward. Perfect. So I want to start today really kind of talking about where SAMHSA is when it comes to suicide prevention and crisis services. As you see on the screen here, these are the list of our priorities and our cross-cutting principles you can see outside of the circle there as well. And so in particular, you can see enhancing access to suicide prevention and crisis care being one of our key priorities. This is something that we are keenly focused on and dedicate a number of time, effort, and resources to this topic. At this point now, there is the suicide prevention branch that is in SAMHSA, which I am the acting, and now of this week, I've moved into the permanent position, so branch chief of suicide prevention. And so this is where our suicide prevention funded activities grant programs all reside as well. We also now have a 988 office that also does crisis coordinating. So it's 988 and crisis coordinating office as well. So we really have two offices, and that office sits within the office of the assistant secretary. So it's right there. It's a key priority for us to move that work forward. And as you can see also, I want to point to, and something I'm going to be spending some time talking about today is talking about equity and how equity infuses into suicide prevention, particularly as we talk about engaging youth and young adults in the work that we do. So again, you can also see promoting children and youth behavioral health is there as well. So protecting our young people is a high priority for us as well. So I want to get into a bit around what we have and what we're doing, particularly as it pertains to youth suicide prevention, to kind of give you a feel. I think many of you are probably very familiar with the work that we're doing here at SAMHSA. But within our suicide prevention efforts, as I mentioned in the suicide prevention branch, we have the Garrett Lee Smith State Tribal Youth Suicide Prevention Grant Program. We also have our Garrett Lee Smith Campus Suicide Prevention Grant Program, which works particularly on our college campuses to do this work and engage with young adults as well. Native Connections is our tribal specific grant program that works around suicide prevention, also substance use disorder issues, really our behavioral health grant program, particularly for tribal communities. And this is a very large grant program. This is a braided funded grant program. So the Center for Mental Health Services, where the suicide prevention branch sits, as well as the Center for Substance Use Prevention, also fund into this grant program, particularly for tribal communities with an emphasis on tribal youth. Many of you also have probably had interactions with the Suicide Prevention Resource Center. How many people know Suicide Prevention Resource Center? Good. Okay, we need more hands next year when I get here. So everybody that's here next year, you have to put your hand up. Our Suicide Prevention Resource Center is our SAMHSA-funded technical assistance center for suicide prevention. If you aren't familiar with it, SPRC.org is where you should go. Our resource library is incredibly vast. They produce webinars, do TAs for state suicide prevention coordinators, crisis care workers, healthcare systems. There's a number of resources there, and the resources in that website are free. So definitely, if you're not familiar, that your sector is probably represented with some resources in the SPRC library as well. So I'm going to spend some time to talk particularly around Garrett Lee Smith, and I'm going to, as I talk about it, talk about some recent developments with the grant program, some things that if you're not aware, I think would be really exciting for you to know about the evolution of the grant program. And so the grant program really got started in 2004. It's our largest funded, if you're not including 988, it's our largest funded suicide prevention grant program that we have at SAMHSA. It is available to states, tribes, and territories. $736K a year for 5 years is the max that any state, tribe, or territory can do. We're now in cohort 18 of this grant program, which is truly amazing, and we're excited to see it continue to grow. And we recently got an increase in our appropriations for this of about $5 million. So we're excited because that's a number of states being able to get, and states and tribes being able to get access to this grant program. One of the things that has happened recently is that what we call the floor of the grant program has been removed. So previously, Garrett Lee Smith was particularly designed for ages 10 to 24. It is now up to age 24. And this is a response really to the suicide rates in our younger children continuing to increase, the need there as well, and a need to go upstream in our approaches for suicide prevention. So we are very excited that now grantees moving forward, when they get funded for GLS, will be able to work up to age 24 and be able to go 10 and under. So we're really excited about that and about that development. Okay, and so I want to talk about some changes, some recent updates to the last notice of funding opportunity for Garrett Lee Smith. These are some of the updates that we've had, particularly in the required activities, the allowable activities of the grant program. Again, talking about equity, making sure that the prevention strategies, the intervention strategies, the things that we're working on, the things that states, tribes, and territories are implementing really address the specific needs of the populations in which they serve. It is important for us to understand that suicide prevention, there are particular risk and protective factors within various groups, various geographical locations, and other intersectionalities that we want our grant programs to be able to address. And so you see that there. We have previously in GLS, if you're familiar with it, there was language around addressing access to lethal means. And in particular, NOFO that was taken out, and NOFO means Notice of Funding Opportunities. I'm a Fed like through and through, so we acronym everything. But that's Notice of Funding Opportunity. And so that has now been placed back in. So reducing access to lethal means is really critical, as it was said in the previous in the previous session, that addressing that and having the ability for our grant programs to do that is incredibly important to the work of reducing suicides among young people. Another area that we really wanted to increase our focus on is addressing the particular needs of individuals with lived experience. So bringing them to the table, not just in a way to tokenize them, but to really leverage their experiences in the work and in the prevention and intervention strategies that we're doing there as well. So you can see that one there as well. And we also added, for the first time in GLS, we added a particular allowable activity around addressing the social determinants of health. This is very exciting to us. We talked about earlier today about the public health approach to suicide prevention and addressing the social determinants of health and those things that impact individuals' ability to be able to live and have a life worth living, and to be able to deal with some of those systemic challenges that impedes individuals and a young person's ability to thrive in their life. We have given the opportunity for our states, tribes, and territories to be able to address that. So we're really excited about this. And so if you all know my predecessor, Dr. Richard McKeon, he would come here and burst through those doors if I did not put this slide in this presentation that really talks about the impact and the evaluation that we did a few years ago around Garrett Lee Smith. And what we saw with that evaluation is that with Garrett Lee Smith, each year that a county, so it compared counties that implemented GLS activities compared to match counties who did not. And those counties that implemented GLS saw a decrease in youth mortality and a consistent decrease with each year that the funding persisted. And then what we saw, unfortunately, is that when the funding stopped, the youth mortality rate went up. This is a critical slide for us. It was critical to have that evaluation, and we're grateful that we have it to be able to show that GLS does work. There is data that shows that we have an impact when we're able to implement this. And so we want to make sure that people know that it's our largest grant program, but not only is it our largest, but it does have impact within our communities. I know you'll have a session on 988 a bit later, but obviously 988 is very important to us at SAMHSA to be able to improve the crisis care system across this country. We are so happy to report, especially when it comes to text messages, our youth and young adults are very much utilizing the text functionality of 988. I don't know if you've met a young person. They do not want to talk on the phone as much. And it also gives them the ability to have some confidentiality. If they can't find a place to get on the phone and to be able to talk, this gives them the opportunity to engage with a trained crisis counselor via text. And so compared to last year, there's been a 1,000% increase in the utilization of text messaging with 988. And that number just gives me chills. Yeah, every time I get the opportunity to say it, and we're excited to continue to have that move forward. Again, I know you'll have more sessions there as well, and I can definitely try my best to answer some questions if folks have that about 988 later. So a couple of other things we have in CMHS, another acronym is Center for Mental Health Services, but we have a Black Youth Suicide Prevention Initiative that I'm honored to co-lead with Dr. Belina Shaw at SAMHSA. And so this initiative is really to address the increases in suicide attempts and suicide deaths among Black youth and young adults between the ages of 10 to 24. So again, in going more upstream, we address ages 5 to 24. You can see some of the things that we're working on, and particularly with this group. We're actually holding a policy academy next month in Baltimore, where we're inviting 8 states to come and develop an action plan to address Black youth suicide within their state. So we're really excited about the work that we're doing there as well. And one other thing that I couldn't get in the slides because it just happened like on Friday, but there is a new, and this was created with the HHS Community Partnership Center in collaboration with the National Action Alliance for Suicide Prevention. But there is a guide coming out very soon. It's in the final stages of clearance. That is a guide for faith leaders to help address youth suicide within their faith communities. We're really excited about this. We've been working on this for a number of years, actually, and so we are excited that that's going to be coming out soon, and more details will be shared at its release. So another piece that I want to mention before I take my seat is that I'm sure many of you are very familiar with the 2012 National Strategy for Suicide Prevention. I am happy to report that we are currently working on a revision to that. That revision was actually requested specifically by the White House. There we go. Specifically from the White House to really address and to create a new strategy. The previous one in 2012 was designed to be around for 10 years, and this one will be released in 2024, early 2024. So this builds off the 2012 strategy and also builds off the call to action that came out in 2021. And so there are a number of folks working on this. I'll talk about some of the various arms that we have here. I think one of the things I want to mention as well is that this national strategy is going to come equipped with an action plan. So we are going to be addressing specific actions that we can take in some commitments from federal agencies about what we're going to do to implement the national strategy, the 2024 national strategy. And so just to give you some background, there's an interagency work group within the feds. It's an all-of-government type of work group dedicated to revising the 2012, building new strategies, new goals and objectives. And so we've been able to have our interagency work groups in phase 1 to do the review of the 2012 strategy. And it's been really exciting to have that engagement as well. We've also done a number of listening sessions for this work, and we've gotten the opportunity to engage with suicide prevention subject matter experts, equity subject matter experts. We also we held a listening session with youth and young adults, and it was amazing. I mean, just powerful stuff that we were getting from youth with lived experiences, various intersectionalities, diagnoses. I mean, it was really just an incredible conversation. And so we are continuing to move that work forward as well. We also talked to SBRC's committee with lived experience in this as well. We also met with the National Action Alliance for Suicide Prevention's executive committee as we're building this out. And we also released a needs assessment that came out to the public, particularly to get feedback on what we should include. And we got over 2,500 responses to that. So if you think my inbox is pretty full with things we need to add in that, it's pretty impressive, but we're excited about this. One of the things I wanted to mention as well is that the White House in particular, they were, okay, so this is the needs assessment and the listening sessions. And what happened as well is that the White House has charged us to really address a couple of particular topics. One is equity and suicide prevention. Another one is the intersection of youth, social media, and suicide prevention, and suicide and the intersection of suicide and substance use disorder. So we are integrating those things as we go throughout this process. And also, as you can see on the previous one, in our strategic directions, there will be a new strategic direction, particularly on the intersection of equity and suicide prevention. So we're really excited about that work and working hard to make sure that that meets the needs of our community. So as you can see there, this is what we're working on now. This is a continuous process. There are so many people involved. There's a project management leadership team that consists of myself and SAMHSA, Dr. McKeon, NIMH is at the table, CDC is at the table, AFSP is at the table at this project management group, and really in our interagency work group, name a federal agency that has a connection to suicide prevention and they're there. VA, DOD, I mentioned NIMH, USDA, is there as well, and IHS is there, Indian Health Service is there, and again, just a list of, I think, at least 30 federal agencies at that table. So we're working on this new strategic direction. We're making updates. We're continuing to go throughout this process. We are very excited in early 2024 to release this to the public, and when things come out, we would love your feedback, and we're very much committed to and looking forward to partnering with other agencies and with other organizations, just such as AFSP, to really move this work forward, because it's a national action plan, and suicide prevention is for all of us, right? To be at the table, to see ourselves, to see where we can make impact, to see where we can move the needle on suicide prevention. So I'm honored to partner with you all on that. You see my email address there. Please don't hesitate to reach out in this new role. Just give me a little bit of grace in how quickly I respond. But other than that, I'm here to talk. I'll be around for a while. I would love to connect with you all. And with that, I'll go ahead and turn it over to Kenneth.
Good morning, everyone. Can everyone hear me? Great, great. It's so lovely to be with you all this morning in person in Washington, D.C. So great, yes. I wanted to start out first by thanking AFSP for holding this event, for having me here to speak with you all. It really is an honor, as Brendan said, an honor and a pleasure. But I also really wanted to thank all of you for your advocacy and for taking the time over the past couple of days to engage in this really important work. So please give yourselves a hand, because you really deserve it. I think I can't overstate the value and importance of, politicians hearing from their constituents, from grassroots leaders, from all of you. And so that work is absolutely critically important to the work that we all do. You have a very talented government relations team at AFSP. You're lucky to have them. I know for a fact because I get the pleasure to work with them, many of them pretty often. But they can't do this work alone, and so they need all of you and your voices there on Capitol Hill, sort of helping them along to do so. So thank you. I also will add that, what I say is not surprising, I'm sure, to many of you. Congress is pretty divided right now. There are a few issues that members on both sides agree on, but luckily for us, one of those issues is mental health and suicide prevention, particularly when it comes to youth mental health. And so we really have an opportunity here with your help to make a difference. Congress has, done quite a bit over the last couple of years to address youth mental health, particularly in school-based settings, but we all know that more can and should be done. And so, as you prepare for your meetings tomorrow, we wanted to provide you with some context about the work that has already happened over the last couple of years, but also underscore some of the data. And I know this data will not be brand new or a surprise to any of you. And you really use that data to continue to make the case as to why more is needed. So that's what we'll start with right now. So before we talk about the state of youth mental health, we need to also mention the state of the mental health of the overall population. And unfortunately, it is quite poor. Data collected by APA show a population experiencing very high levels of stress and anxiety, with a quarter of US adults reporting they're too stressed to function. Almost 3 out of 4 Americans are feeling overwhelmed by the number of crises facing the world right now. And with that in mind, it's not surprising that psychologists report the demand for treatment for anxiety and depression remains extremely high, especially among populations of color and young people. There we go. Children are, of course, they don't exist in a vacuum, and they are also subject to many of these same stressors. And in fact, the mental health of children is frequently tied to the overall health, safety, and stability of their surroundings, including their communities, their homes, and their schools. In 2021, 1 in 5 high school students said they witnessed violence in their communities, 3.5% said they carried a gun, and nearly 9% reported being victims of sexual violence. Such forms of stress and trauma often have downstream effects on the mental health and well-being of young people, potentially leading to substance use, affecting their brain development, and even causing chronic illnesses such as heart disease and cancer. At the same time, it's already having an impact on their mental health and overall well-being. Nationally, diagnoses of depression, anxiety, and post-traumatic stress disorder in children and teenagers increased by 12% between 2020 and 2021. According to the CDC, 42% of high school students said they were consistently sad and hopeless. And this was especially pronounced among female students, Hispanic and multiracial students, and LGBTQ students. And I know I don't need to tell this group, but there are obviously clear linkages between mental health and suicide, and the data is very clear on that as well. About 20% of high school students considered suicide in 2021, with female and LGBTQ students reporting particularly high levels of suicidality. In fact, suicide rates among the 10 to 24 age group reached a 20-year high in 2021. We're also continuing to see an increase in demand for pediatric inpatient services. Between January of 2020 and December of 2021, kids who remained in the emergency department for more than 24 hours accounted for 7% of pediatric mental health visits. And while this phenomenon has rightfully gotten more attention during COVID-19, it really does predate the pandemic. Over the 11-year period between 2009 and 2019, hospitals beds occupied by children with suicidal or self-harming behavior increased by a staggering 163%. At the same time, as with many factors within our society, we're seeing even more troubling numbers from youth within racial and ethnic minority populations. Rates of suicide have traditionally been high among white and Native American kids, but they have also risen sharply among Black and African American youth. Nearly 300,000 children lost a parent or a caregiver due to COVID-19. And we know that this kind of profound loss can have significant impacts on the mental health of all children. But children of color are being impacted disproportionately, with many of them losing parents or guardians at much higher rates than their white counterparts. In many ways, perhaps the most at-risk population of youth right now is the LGBTQ plus youth, who are much more likely than their peers to face pervasive discrimination in school, including sexual and verbal harassment, violence, and bullying. Nearly half of LGBTQ plus youth seriously considered suicide in the past year. And this is further compounded by the record number of states that are proposing discriminatory laws over the past 2 years. And data show that these kind of policies carry a great deal of danger to the mental health of LGBTQ plus young people. And what's especially striking is this is not limited to those that live in states that are proposing such laws. Recent data actually do show that LGBTQ plus students around the country are paying attention to how their rights are being impacted, and this is having an impact on their mental health, even in states that have affirming laws. So the stakes of untreated mental health symptoms for children and adolescents are exceptionally high. Failing to detect and address early indicators of mental health disorders can have profound consequences on the overall trajectory of a child's life, including a greater likelihood of difficulties with learning, addiction to substances, lower employment prospects, and involvement with the criminal justice system. So what can schools do to address this? And the answer really is a lot. I think much of the way that we address our mental health in this country on a systemic basis is typically through crisis response. We wait and wait and wait until someone is in crisis, and only then do we deliver care, and even in those cases, not all the time. But if we want to successfully address our mental health, going forward, what we really need to do is look at a new approach and really center prevention and early intervention in that work. And this is especially true for kids. And we need to meet kids where they are, and most of the time they are in schools. About 70% of children receive their first mental health services at school, and students are 6 times more likely to do so if schools offer those kinds of services. Despite some of the really troubling data that we've seen from the CDC recently, the sort of silver lining of that is that over 60% of kids said that they feel connected to their schools. So we really do have an opportunity to make a difference here. And so for the most part, the value of having mental health services in schools is widely recognized and supported. Instituting evidence-based comprehensive behavioral health systems in schools can help reduce the frequency and severity of mental health disorders and improve academic success. It could improve school climates. In addition, integrating evidence-based social and emotional learning programs helps develop skills such as motivation and engagement, problem solving, relationship building, resiliency, agency, among others. And these are all skills that, if you ask parents, most parents across political affiliations want their kids to have these kinds of skills. And to that effect, I think it's also important to remember that in some cases, this should be built on collaborations between parents, families, educators, and of course, school-based mental health professionals, including school psychologists. So the good news, as I've mentioned, that Congress has made some significant progress in the past several years in investing in school-based mental health services. Between the 3 COVID relief packages passed in 2020 and 2021, between 2 different administrations, I might add, Congress provided nearly $200 billion for education. Not all of these programs are, of course, all of this funding will, of course, go to mental health programs in schools, but data has been collected since then, and we see that districts are using the funds on mental health services. And in fact, that consistently ranks among the top 1 or 2 items, or 2 or 3 items that superintendents and state school chief officers spending these funds on. In addition to the COVID relief bills, in 2020, after the tragedy in Uvalde, Texas, Congress did pass the Bipartisan Safer Communities Act, which included another $2 billion for school-based mental health services through both the Department of Education and SAMHSA. And so that did include specifically $1 billion to grow the workforce of qualified mental health professionals in schools. And it also did direct SAMHSA to update its guidance on using Medicaid for school-based services, and CMS actually just did that recently. However, despite these very positive actions, most schools continue to struggle to provide these much-needed services. According to recent data from the Department of Education, more than 2/3 of public schools saw higher percentages of their students seeking mental health services in 2020 than before the pandemic, but only about half report being able to meet these heightened needs. And furthermore, the vast majority of states and school districts across the country still do not meet the recommended ratios of school psychologists, school counselors, and school social workers. And beyond just impacting a student's mental health, this is also affecting their education. More than half of teachers report that the current state of students' mental health is hurting their ability to learn and socialize, and also stressing educators' own capacity to manage their classrooms. So what more can be done? And frankly, quite a lot. As fantastic as all of this recent funding has been, it's been done on an emergency basis in a response to an emergency, and it is all temporary. So what we need is to provide schools with long-term sustainable resources that, where we're not just lurching from one crisis to another. One way to do that is to provide steady annual appropriations, very important, but also to authorize key legislation that authorizes, new programs or changes current programs to expand them. And one such bill is the Mental Health Services for Students Act, which I know is one of your legislative requests on the Hill tomorrow. And so Joanna will expand on that in a little bit, but just to give you a brief overview, the bill was first introduced in 2007 by Congresswoman Grace Napolitano from California, who I know you heard from yesterday. And it's based on a successful pilot project that was launched in her district in 2001. Since then, there's also been a Senate companion introduced by Senator Tina Smith from Minnesota. And the bill expands SAMHSA's Project Aware program by providing $300 million for schools to meet the mental health needs of their students by building community partnerships and also training the entire school community on recognizing signs of mental health concerns. It did pass the House in the 116th and the 117th Congresses, but not yet this Congress, and it has never received a vote in the Senate. So really now is the time to get this job done, and that is why your advocacy is so crucial and important. So again, thank you so much. I will now turn it over to Joanna, and happy to take any questions you have at the end.
All right, well, hello, everyone. Can you all hear me? Is this good? All right. Thank you once again, Brandon and Kenneth. Those were incredible presentations, and now I have to follow you, so thank you. I'm really, really excited to be here. As Laurel had mentioned, I was previously an intern with the policy office, so this forum is really near and dear to my heart, and I'm just really grateful to be here. I'm also much shorter than you may have noticed on the forum last year, which was virtual. So again, really excited to be here in person, even though, I'm exposing myself. So before I get started again, just want to give another round of applause to Brandon and Kenneth for being here. We are so grateful to the APA and to SAMHSA for your partnership and dedication to these issues. We've heard a lot of drastic, sobering statistics today, but we've also seen the graphs about how we can actually make a change and how funding and support for the legislation that we're talking about today can really make an impact and improve suicide prevention for youth. So, we heard about what SAMHSA is up to and the climate of youth mental health. We've heard about what Congress has been up to in terms of a comprehensive background, on what Congress has been doing to prevent suicide among children and young adults. And tomorrow you're going to be going up to the Hill to ask your members of Congress to support specific bills. What I'm going to do is break down the bill that Kenneth mentioned, the Mental Health Services for Students Act, which you'll be asking your members of Congress to support or thanking them for already supporting. Let's see if I can get this working. there we go. My team knows I am terrible with technology. Just a heads up, if you get an action alert tomorrow to email your members of Congress, if it worked, it was from Claire on the state team, and if it didn't, it was from me on the federal team. So the bill that we're focusing on this year is the Mental Health Services for Students Act, HR 3713 in the House and S1884 in the Senate. This is bipartisan legislation, so it is supported on all sides. Republicans, Democrats, we can all rally around the fact that we need to support our children in our schools. It is sponsored by Representatives Napolitano and Fitzpatrick in the House, and Senator Smith, Senator Cortez Masto, and Senator Murphy in the Senate. Right now, the House bill has been referred to the House Committee on Energy and Commerce, and in the Senate side, it is in the Senate Health, Education, Labor, and Pension Committee, which we also lovingly refer to as the HELP Committee. Something to keep in mind also is that Senator Bernie Sanders, who is the chairperson of the HELP Committee, is actually also an original co-sponsor of the Senate version of the bill. So that's something to keep in mind. It's always good to know, the members of Congress that you're meeting, if they are, members of key committees, or if they are sponsors of the bills that you're going up to the Hill to ask them to support. All right, so as Kenneth mentioned, the bill has been introduced every year since 2007, I believe it was. So this bill was introduced last year, as we all know. It passed the House in the 117th Congress. However, it was never considered in the Senate, which means that it could not pass through the Senate, which means that it could not be signed into law. So when that happens, the bill has the chance to be reintroduced in the next legislative session when Congress returns to work. So the current Congress, the 118th Congress, you'll hear that tossed around a lot, came back to work in January of this year, and we're really excited to try to rally around this really important bill because obviously the time is now. We can see, the statistics are really telling us that this is something we really need to be focusing on. So in the 118th Congress, the Mental Health Services for Students Act has been reintroduced in both chambers just about a month ago. Each version is pretty much identical to the previous year's version, with the exception of the funding level having increased over last year's. And I'll get into that in a bit. The House and Senate bills are slightly different from each other. The intent is the same, the level of funding is the same, but there are some slight differences from the House to the Senate version. The main thing to remember is that the Senate bill from this year is exactly the same as the Senate bill from last year, and the House version is the same as the House version from last year as well, with the exception of that higher funding level. All right, so what exactly does this bill do? I'm going to break it down for you here, and at the end of the session, we're going to have a Q&A. You'll be able to ask myself, Brandon, and Kenneth any questions that come to mind, but I'm just going to break this down, try to get through it pretty quickly because we're running out of time. But the magic number to remember for this bill is $300 million. So this bill authorizes $300 million in grant funding for SAMHSA for on-site mental health services for students. So this is going to be for public schools that are eligible for these grants to implement comprehensive, culturally and linguistically appropriate services for students. Now, those are some tricky words. What that means is that depending on the ages of the students in question, the programming and the services have to reflect the maturity of the students in question and have to reflect their levels of understanding and their ability to process information and then adequately sort of contextualize their feelings and emotions. The grants are going to cover primary and secondary public schools as well, so that's something to keep in mind. The bill, as Kenneth mentioned, expands SAMHSA's Project Aware program to create guidelines for and measure the outcomes for each grant recipient and provide access to licensed mental health professionals for students. So Project Aware is, it stands for Advancing Wellness and Resiliency in Education. And this is a grant program already through SAMHSA that helps to build and expand on the capacity of state educational agencies and state mental health agencies to increase awareness for mental health in schools and across states, territories, and tribal communities. So the program also provides training for school personnel and other adults in the communities so that they can flag and respond to mental health challenges and needs of their students, and then connect the students with the services that meet those needs. So the Mental Health Services for Students Act also focuses on engaging the entire community. We've talked about upstream efforts in terms of making sure that we're meeting kids where they are, making sure that we are addressing the needs ahead of a crisis. So we really want to focus on the entire community, not just the teachers in the schools, but the parents, the guardians, siblings, other adults, who are interacting with the kids in these communities to create a positive environment around mental health. Reducing stigma is really important. I know we all know this, but we need to make sure that students feel empowered to bring stuff up with their trusted adults. Reach out when they need help, and feel comfortable and empowered and supported when they do. So by expanding the scope of Project Aware grants and creating grants that will enable more public schools to place counselors in schools, to support the communities that are supporting their students, this is going to free up teachers so that they can focus on teaching their subjects while the students can still be receiving comprehensive, culturally and linguistically appropriate services that will support their mental health needs. And again, this means that the grants that are offered need to be tailored to the needs and the levels of understanding of the students in their communities, so that again, kids are equipped with language and awareness that matches their maturity level, so that they can express how they feel accurately and feel empowered to reach out and say, hey, I need help right now. So this bill, again, will provide $300 million to fund these grants. Remember, that is the magic number. This is something that offices are probably going to ask, how much does this authorize for the grants? And this is definitely something to keep in mind. Another thing that Emily is going to address in the 988 session is the difference between authorizing and appropriating. But authorizing these funds doesn't actually mean that they'll be automatically available once the bill is passed. That needs to be appropriated in the budget process. Again, Emily's going to go through that in the 988 session. Just want to also give a heads up that the previous funding level from the year before was $130 million. So it is a big jump. We recognize that, but obviously, and clearly the statistics show us that these grant programs can really make a difference and can really support these students. There we go. Now, as I mentioned earlier, the Senate and House versions of this bill are slightly different from each other. I'm not going to go too far into detail on these because you don't really need to know the specifics. If any offices are confused and asked, please always let them know. Our public policy team is ready and waiting to answer any questions they might have. You can give them our email address, advocacy@afsp.org. But I just want to let you know the Senate version lays out specific requirements for the types of services that the grants should fund, whereas the House is a little bit less rigid in its definitions. The Senate version also breaks down measurements for success that each grant recipient would have to report on once their grant period is over. Again, the main thing to keep in mind is that the authorization levels, so the total amount of funding for all of the grants, is the same across the House and the Senate, $300 million. What's that number? So for each bill also, the individual grants can't be more than $2 million for each fiscal year from FY24 to FY27. That's not as important for you all to remember, but if they ask and you happen to remember, that would be great. If not, again, always, if as Bill said, if you don't know the answer, always let them know that the public policy team is happy to respond, happy to follow up. Feel free to give them our email, flag their email for us, and let us know later. Like I said, we're always happy to make more connections with them. And offices probably shouldn't ask you the specific differences, but again, it's just good for you to be aware that there are differences. All right, so I just threw a lot of information at you. Thank you all for bearing with me. I just want to take a moment, recap the main points. You have one-pagers, with all of this information, and there is a fact sheet for each bill that you'll be asking your members of Congress to support in the packet that you'll be giving to the legislators. So you won't have to remember all of these off the top of your head, but these are just some key talking points. I just want you to keep in mind, we know youth are at increased risk for suicide. We know that meeting kids where they are in the schools is a really effective way to prevent suicide, to support the mental health needs of these students. And this bill, the Mental Health Services for Students Act, will ensure that more counselors and resources are placed in schools across the country to address those needs. So our ask is that members of Congress support HR 3713 and S1884, the Mental Health Services for Students Act. And if they've already supported it, thank them for their commitment. Ask them to get their members of their colleagues to help support as well. Any help we can get is always wonderful. And thank you again, for your attention today. I see the countdown going. But I just want to say thank you once again to everyone here for all of your attention. If you have questions, write it on a card. One of my team members will come and grab it from you. And we're excited to answer your questions and have a great discussion. Thank you again for joining.
Great. Okay. So we have a number of questions. I'm just going to give everyone a heads up. We don't have a ton of time and likely won't be able to get to all of the questions, but we do have several other times throughout the day where you'll be able to either A, find one of us on the public policy team to ask, or at, I think it's 3 o'clock, the Fed team is going to come back up. It'll be me, Joanna, and Bill. I'm Emily, for those who don't know, Senior Director of Federal Policy, and go through these talking points once again. So if you don't get your question asked now, please don't fear. We'll get to it later today. So I'm going to start with a basic question just to make sure that we're all on the same page, which is, can you explain again for people what a grant is? For example, what does grant funding mean?
Yeah, I can. As one of the places that funds a lot of stuff, I can answer this one. Grant programs in particularly are funding. So for SAMHSA in particularly, so our grant funds are funds that are, again, as we talk about the appropriations process, there are funds that are appropriated to us for us to be able to give out to specific organizations. Usually a lot of in SAMHSA, especially in suicide prevention, most of our grants go particularly to states, tribes, and territories. Obviously, we have our campus grants. We have we have a new community crisis response grant program that goes in particularly to crisis teams. And so essentially what it is that in a particular grant, there are specifications on what the funds can be used for. Usually we have a set of required activities. These are activities that you have to do with your funds as a part of the grant. And then there are allowable activities, which means these are things that you don't have to do, but it would be great if you could. You can do them, and they, should have impact within your community. But it's up to you whether or not you want to engage in those. And then because we're the federal government, there's a big list of things that you can't do with the funding. But really, these are just dedicated programs to address usually particular pieces of suicide prevention. So again, like I said, in that chart, there are a ton of other grant programs. In the interest of time, I don't want to go through them all, but essentially it's funding that is given to us by Congress to be able to give back states, tribes, and territories, communities to be able to implement suicide prevention work.
Great, thank you. We heard the statistic 20% of youth have considered suicide. How many have made an attempt? Is it 9 to 10% overall, or is it 9 to 10% of those who have considered suicide?
So, okay. The 2021 YRBS study tells us that about 10% of high school students made an attempt. Now that is 10% of the students that responded to the YRBS, which is the Youth Risk Behavioral Service. Service? Yeah.
Youth Risk Behavior Surveillance.
Yes, yes, surveillance. Yes, sorry. Too many acronyms. So that we have about 10% of high school students that made an attempt in 2021. That is the data that we've gotten. But again, that's just the high school students who responded to the survey. So this is the best statistic that we have that sort of gives us a picture. Not everyone does respond. Not every high school runs the study. So that is the most complete data that we have at this point.
Thank you. How do we handle private school prevention programs around suicide? Will this bill specifically cover both public, private, also preschools, homeschooling?
I believe the bill, and I can be corrected if I'm wrong, but I believe the bill only covers public schools.
Next question. How will the shortage of mental health providers impact the success of this act?
I mean, it's up to you.
So the bill would, the grant funding would provide the funds to put more counselors in schools. Like I said, the Senate version has a lot of specifications, and I believe there is a teacher to student ratio that they, or a counselor to student ratio that they want achieved. Or, you know, if a school doesn't meet that specific ratio, they will, you know, have, they will qualify for the grant program. So the half the point of the bill is to address that workforce shortage and put more counselors in the schools. It also puts more resources in the schools, but you know, making sure the counselors are available to the students is half the battle.
Yeah, but I will just add that you know, this bill is fantastic and we've supported it for a long time, but it's not the only issue. As you mentioned with workforce shortages, yes, we need to get more of these folks into the school-based setting, into the classroom. But there's just not enough of them in some places, and so those are the kind of barriers that I know a lot of school districts are facing. That's why a lot of the funding that I mentioned through the Department of Education also that funds the pathway to a degree in a school-based mental health profession, whether it's a counselor, a psychologist, a social worker, is also so important, and it goes really much hand in glove with providing schools the resources that the Mental Health Services for Students Act would do in hiring more of these folks. But at the same time, we also need to train more of them and get them into the workforce so that schools are able to hire more of these folks. So it's very much goes hand in hand with some of the work that's already being done and needs to be done further.
What sort of specific training is provided through GLS? Does this include Talk Save Lives, Safe Talk, other programs similar?
That's a great question. So really it is any evidence-based program for training. So there is a big training component to GLS, and really we allow the grant programs to be able to tell us when they apply what training programs they're going to be able to utilize. We certainly are open to our grantees making adjustments in that process, but we want those things to be informed by evidence. Practice-based evidence-based programs. And also one thing that I didn't mention is that the Suicide Prevention Resource Center is now building a best practices registry for suicide prevention. They are currently accepting applications. So if any of you have any programs or interventions that you want included on that, there is an application process that you can fill out at sprc.org, and this is helping us to build that evidence base. So when people are applying to our grant programs, they can look for things that meet the needs, particularly of their community, because we want those things to be targeted.
What were the reasons the bill has not been able to pass historically? And this may be our final question, so folks, keep your questions in mind. Were the obstacles mostly financial, or were there other objections from policymakers?
That is a very good question. I think a lot of the time, financial, the numbers are big barriers. Sometimes also, you know, it's a matter of prioritizing for offices and for committees. Because the committee needs to, you know, report out a bill, and if they're focused on another issue or another specific piece of legislation, it doesn't always make it through. Sometimes there's just not a great answer for that question, unfortunately, but that's kind of why it's so important that we are able to go to the Hill, share our stories, and connect you know, your individual experience with why this bill would help save lives in the future. Kenneth, I'm not sure if you know anymore, but
Yes, that is a very good question. My mic is not on, but I have a loud voice. We've been working on this bill since 2007, and while that may seem a long time, let's remember it took 10 years to pass mental health parity. This legislation, and that's why your voice is so needed, because we have to keep up that drumbeat and build the support. Sometimes it's based on political will. Sometimes it's based on, there's competing bills. There's many bills in Congress, many school-based bills. And so we have to make sure that we are fully committed and
continuing the drumbeat on this legislation. It is bipartisan. It is bicameral, except for in the Senate, it is not bipartisan yet. But that is also a job that we could do. When we're meeting with our Republican senators, we can ask them to co-sponsor this. And so we can make this bipartisan legislation. So it's just a matter of a variety of things. And I just want to keep reminding you that is why your voice as a constituent, a voter, is so important to this process. We came close to getting this bill done last year. We came very close. A little disappointed. So we're going to try to push this over the finish line. Personally, I feel like, Congressman Napolitano, who was the architect of this legislation and the co-founder of the Congressional Mental Health Caucus, this is one of her chief bills. And we're going to do all we can to get this enacted, not only for her, but also because we know that this grant program will make a difference in addition to all the other supports that we are pushing for. So thank you. I think that was the last question, right? So I also wanted to make sure, I know people were taking pictures of the slides. Those slides will be in the Google Drive. And so you can access those. Also, Soapbox tool, the documents there have all been, the fact sheets have been delivered to your congressional staffers already, but you'll have those, but sometimes you might get an office, they're like, may not remember, they're really busy. So you have those one-pagers for them. And then also remember that on your Soapbox tool, you'll be able to see whether or not your member of Congress or senator has already co-sponsored these bills. So then you will then thank them for that. And those that haven't, you will make the request. And with that, I want to thank Brandon Johnson, Kenneth Polzachuk, and of course, Joanna, for just this wonderful, informative session. Thank you for sharing your expertise. Thank you for all you do on behalf of children. Thank you. Thank you to Joanna, Brandon Johnson, as well as Kenneth Polzachuk for their participation, and a special thanks to Congressman Lawler for his remarks. Now we will transition to our keynote presentation for today's event. Remarks from U.S. Congressman David Trone. Congressman Trone co-founded and serves as the co-chair of the Bipartisan Mental Health and Substance Use Disorder Task Force, alongside Democrat Andy Custer and Republicans Brian Fitzpatrick and Lisa McClain. Last Congress, the task force introduced over 100 bills, 26 of which passed into law. Congressman Trone is driven to deliver accessible, affordable mental health care and is working in Congress to do just that.
Good afternoon, everybody. First of all, I just want to thank you for all the work you guys do. I mean, day in and day out. I mean, we're in a battle here, and we're losing the battle in a lot of ways. And the only way we're going to turn this around, erase the stigma, get the therapy, the services that are needed, is by continuing to focus, work together as a team. And we can drive these issues and make some progress in the federal delegation, but also in your state houses, because we've got to make it happen everywhere we go. So it's really crucial. You know, a little bit about me. I'm Maryland's 6th District, which is Montgomery County, Frederick, out to Western Maryland. Ironically, I also own a business, even though I do a lot of work in addiction. My work is mostly two big areas. It's addiction and mental health. And I come about those honestly. In the addiction space, I lost a nephew to fentanyl, to an overdose. I have one of my children's been addicted for many years and is in recovery and doing great, knock on wood. And we also have dealt with the mental health space. That's personal too also. And so, you know, we in our family have mental health issues, challenges run through the family. So we live this literally every single day. And on this big issue we have here today on suicide, you know, we've had experience with that on a couple of occasions, and the very close personal group we have in Central Family and slightly extended with a couple different individuals. So I dealt with this right up front and been through it personally multiple times. So I'm on the team. I'm on the team because I lived it and I'm committed to it. But ironically, I also own a business in the wine business. So I hope I have a few customers here. So Total Wine and More is my business. We operate in 28 states. We have about 260 stores in Texas, Florida, California. They're my biggest states. So that's the sidebar. But that's what's enabled me to be able to come here and do this work and not take money from PACs, not take money from lobbyists, corporations, and use a lot of my own personal funding to help drive my campaign. So I think when we've been fortunate, we've been lucky, it's an opportunity to give back. That's why I do this. I'm in my third term now, and I sit on the Appropriations Committee. That's the right spot to be. We got on there second term because we worked with Speaker Pelosi, and she was very supportive. And, we're in a good spot right now. And we're also, as a sidebar, working to run for the next level of the U.S. Senate, but another battle. But what this is about today is, 48,000 folks. It's just unacceptable. It is just simply unreal. It's unimaginable, but it's continuing to happen. And we see the same thing, obviously, with addiction and opioids. 110,000 people on overdoses last year, 80% which were fentanyl. So we've got these twin crises of mental health and addiction, and they're merged. They're co-occurring. I don't have to tell you guys that. Then on top of that, we got the whole issue on gun violence. Of the 48,000, 26,000 were by weapon. And that's the issue, of course, is it's irretrievable. And when someone has an overdose of pills, and I've dealt with that type of thing, you can do a lot of things to help pump the stomach and get back. And sometimes it's maybe not all there. They don't maybe not want to go. But we're making a statement, of course, sending a message. But when someone makes that one impulsive second, that's why we have to do so much better. We've got to eliminate all these weapons of mass destruction. They have to go away 100%. When we have one death every 11 minutes, it's unbelievable. The other thing I'm concerned about is our LGBTQ community. I was just at Pride Saturday morning. We had a big Pride brunch in Baltimore. Then I marched with my team in the Pride parade through Baltimore. Then I went that night to the Pride Festival in Frederick. And we have an LGBTQ individual every 45 seconds attempting suicide. It's pretty unreal. Folks in our trans and binary community, 50% have made efforts to commit suicide. So we've really have our work, cut out for us. And so many of our communities are really suffering. When you look at kids 10 to 24, and the second cause of death is suicide. And of course, you look at adults 18 to 49, the number one cause of death now is overdoses. So, these two things are ravaging our country, and we're starting to get some traction in Congress. And we're not winning, we're losing. And we got to be clear about that. People like to declare they won and move on. We can't let that happen. You can see progress, but you got to make it clear we're losing. We're losing until we get these numbers down to as close to zero as we can get them. Until then, we're losing. And we got to fight like we're losing and have that sense of urgency and that we're losing, because we are. So, but in Congress, with so many folks now have died, over 1 million now from addiction, overdoses, and the suicide numbers are equally monstrous. It's starting to where it's reached a point where, sadly, it's affected most members. If their family hasn't had it, their next family has. Their team members have. And that's what's enabling us to get more of a critical mass. I've been on these issues since 2016, and it was much more alone at the time. But now we see so much more coming around, and our bipartisan working group, as she mentioned, 140 members. We had 100 bills last year on addiction and mental health. Everyone bipartisan. Got to be bipartisan or we're wasting our life. I mean, I'm a progressive Democrat. I got it. But at the end of the day, if we don't pass something, we're just talking to ourselves. We're wasting our life. So I work really hard across the aisle, and I think that's what's helped us a lot, because I spend all my time on the Republican side getting them on my bills. It's like, and they look at me and says, there's Trone, there he comes again. And they hide in the cloakroom. I chase them in the cloakroom. You know how many Democrats I've seen in the Republican cloakroom in 5 years? 0. Just me. Just me. But I go back after them, and they know that, and I eat chili cheese dogs with them. The Democrats, we have veggie burgers. That's true. Sad. But I like the chili cheese dogs way better. So, but seriously, we sit back at the little hut there, and you pay $2 for a chili cheese dog, and you can sit there and talk to them and build a connection. I bring them to hockey games, basketball games, my house for dinner, and try and build a relationship. But if we don't build relationships across the aisle, we ain't going to get anything done. If we don't get anything done, we're not saving these lives. So last year, I was ranked the 10th most bipartisan member of Congress. That's a good thing to be. And, we got to keep finding those kindred spirits that get it and that are on the same page and are there to get things accomplished. I'm more of a policy wonk and not a TV wonk, because I think we get it done in the policy and we get it done in appropriations. And, of course, one of the biggest areas of appropriation we're trying to get done, and this year we're getting hammered. The MAGA Republicans are hammering us. We made a deal in the 23 deal for a 23 budget. That was the debt deal for the ceiling, 23 numbers. And they were good numbers. We had a good Biden budget. But they're reneged on their deal already. So every appropriations bill we did in the last 2 weeks, 4 of the 12, they've reneged and done 22 numbers. Not 23, what they agreed, but instead 140 billion less. It's all come out of everything but defense. Coming out of things that affect people, hurting people. So that means you've got to, when you do your Hill Day, you've got to be clear when you talk to your Republican counterparts that, hey, this is bipartisan. We're all dying. Why are you cutting back to 22 in the Appropriations Committee when the deal with the president was 23? Why are you doing that? And then you got to work on your senators, because what will happen on the appropriations bill is they'll come out of the Senate and it'll be 23 numbers if we make it happen, because they read the deal. And I think they'll be honest with it and do 23 numbers. Then it's just going to come back to the House to vote it up or down. So we got to make sure your members in the House that are moderate when it comes back, because the MAGA Republicans, all they want to do is shut the government down. That's all they want to do is shut it down. They have no other interest other than close the government and make a statement. That's not going to help anybody. It's going to hurt everybody. So we've got to talk to your senators to get it over, and your moderate Republicans, the Democrats, we can vote with them and we'll get a budget passed. But we got to pass a budget. We can't wait till March. The budget ends September 31, and they're very happy to do a shutdown or CRs that continue forever. And CRs hurt the efficiency of government. Every month we do a CR, after 2 or 3 months, it just goes backwards, because government doesn't have the funding. They know what the funding is going to be. And we're working on the previous budget. So you have a lot to do in your Hill Day. Yeah, you'll need them. I just quickly want to talk about a couple of things that we did get done. As you know, the Restoring Hope and Mental Health Act, that was a big bill at the end of the year. I mean, Frank Pallone and the Energy and Commerce Committee, we worked really hard with them, got 30 bills passed on mental health in that last omnibus day. 30 bills, 8 of which were ours. So we're pretty pleased that E&C and Frank really stepped up. So folks from Jersey, put the good word in for Frank Pallone. The other issue is The Bipartisan Safer Communities Act, AKA the gun bill, you know it well. It's really didn't do anything for guns to speak of. I mean, it was lip service, but we got great $11 billion for mental health. That's pretty unbelievable. So 3 billion of that is going to come out for kids K to 12. And that's where they really need some help in that area. But we haven't begun to give it out yet. So what's happening is President Biden, his numbers are in the tank in a lot of ways. But I'm a huge Biden supporter because what's happened in his first 2 years was transformational. I mean, the Infrastructure Act, 1.3 billion, those jobs, those improvements to our lives, we were 13th in infrastructure, 13. That's going to happen the next 2, 4, 6, 8, 10 years. It's all going to roll out. People haven't seen it. You look at the Chips and Science Act. I mean, manufacturing is coming back clearly in chips and science in the U.S. Big jobs, 6-figure jobs. It's going to make a huge difference, 280 billion. And the Inflation Reduction Act, nothing to do with inflation, forget that. That was all about the environment. 370 billion, the biggest change ever in our lifetimes. Probably the biggest we'll ever see in our lifetimes, to drive a clean environment for your kids and my kids. I mean, amazing what got done. But all these take time. So that 3 billion, they haven't figured out how to spend the money yet. So they're still figuring it out. Government doesn't move too fast, I found out. Was there a surprise there? No. But it's unfortunate, but it's going to come out. It's going to be transformational. So when it does, we got to make sure it gets to the right places. You know, come to the states, then it's going to move out to the schools. So that's important. New mental health bills. You know, right now we have one for higher education on mental health. Our kids in colleges also have really had a tough road with COVID. You know, being absent, dealing with that. I sit on 3 college boards. I know the drill. My foundation, we spent $10 million to my alma mater for one thing, mental health. And my idea was create a paradigm of what's right for mental health at my university, Furman University, Greenville, South Carolina, where I went undergrad. And we can set that, what that should look like with that 10 million. Other universities might say, we got to keep up with them. And maybe they can get donors to step up instead of building a basketball arena. How about we have a donor build great mental health for their college? Would that be good? Yeah. So a lot's going on. Those are the big issues. But of course, we got to get mental health parity. You see it every day in the payment systems. So what I ask of you as I close is we need you to partner with us. We're executors, but you know what's broken. You're living it. You see what's broken. You see what's broken in Medicaid and Medicare and Social Security, everything else that ties in some way with mental health or anything in government that's not working. And it may be state government, and we can put a word in with our governor or someone else's governor that we talk to the member of Congress, and they all know their own governor. But we're looking for your ideas. We're looking for you to bring us ideas of what's broken and your ideas of solutions. You know, as a CEO all my life, I want folks to tell me how I can be different. Tell me how I can change, because change is good. And it's uncomfortable, but it's good. But you got to bring those ideas and your ideas on how to solve it. And that may not be the perfect idea, but it's going to get us started. We got to get started to do more and more. But it's got to come out of this group and other groups like this. I talk to all the activist groups on mental health, addiction. I talk to everybody I can. And we're always asking them, help bring us ideas. What we can do with our prison population, so to speak. We got 2 great bills this year on getting the Medicaid. Our due process continuity of care bill. It's going to keep people with Medicaid, which you lose when you're arrested, not adjudicated. Just arrested, you lose it. We have another bill Paul Tonko did. We're working on that bill with Paul, so you get Medicaid 30 days before you leave prison, because we got to give folks a second chance. So we do a lot in the criminal justice space also. So I have a second chance caucus I just formed. I got 20 Republicans and 20 Democrats. And the Democrats are moderate ones, not ones that are going to scare people away. Because if you don't do that, you won't get Republicans. So, and we're having all the ideas are coming from Republicans that are really committed. Sheriff John Rutherford in Jacksonville, fantastic ally, helping us be smart on crime. Everything we see in this room that we like to do to make a more just system, which is certainly racially biased and a racist system for forever. I mean, he's on board with us. He's on board because he's seen it doesn't work. And we got Kelly Armstrong from North Dakota, lawyer in the public defenders area. He gets it completely. So there's good Republicans out there that we can use to work in this area. So we really need your help to help us. But we got the people, the connections to move it to the finish line. But we got to get your ideas. That's it. Thank you very much. Okay, that's very kind of you. Trust me, we're going to continue to bust our ass. That's what we do. Okay.
Questions? Yeah, as questions are coming in, I'll just help get the blood flowing. Congressman, our asks for tomorrow are going to be focused on veterans, youth, and 988. Do you have suggestions for our advocates and volunteers around how to build bipartisan support for those issues in particular? Or is there one that you've found particular bipartisan support that they can kind of start with to help build momentum?
So momentum on 988, we fielded what, 2.1 million calls? I mean, the numbers are mind-boggling. I mean, 988 is just rocking. And I'm not sure everybody has really spent the time on it. So if you can get your members to talk, to know about it, because a lot of them don't know about it. We visited them and talked about them and newslettered about them, and we're like excited beyond belief. But you know, this is a big deal, big deal. I mean, one call, you know it, one call can stop that impulse. Then we save a life. It's unbelievable what that is going to do and is doing. So I think you got to get them to be aware of it, get their district directors. So they've got a chief of staff here and a district director out there. You'll get them to do events at the call centers in their district, if not near their district, and build the awareness of it, because we got to get everybody to know somewhere you can pick up the phone and get someone that really, really gives a damn and wants to help you. It's qualified. And so we got to get that. We just got to build it. And I think it can be transformational. Okay, good one. Next one.
I've got a good one for you, Congressman. The future of mental health. What should we do next?
Wow. Man, I got to go to the next event. All kidding aside, you know, I mean, I think we're on the right track. I mean, Speaker Pelosi said on one of our caucus calls while she was still Speaker, she said, you know, we just got to get our focus on this mental health piece. We talk about it, we do a little bit, but we just got to figure out how to get it, all of Congress, you know, focus on it. And, you know, I think you've just got to, I just think you got to get Republican senators on board. At the end of the day, we're going to take back the House in 24. I mean, I know Hakeem well. I know the game plan. I know all the guys that are frontliners. I write checks to everybody. I know all the red, the blues. I write checks to them. I mean, we're helping drive this. We're going to take the House back in 24, but the Senate's a bad map. There's 24 Ds up and 9 Rs. So we're still going to be behind, if not underwater. So your focus really, and all of our focus has to be developing relationships with Republican senators. And we did a lot of research, figure out who had some mental health in their family, who had some challenges. You know, maybe some of their staff had some issues that you find out about when you listen, and then try and make it personal. When things are personal, it matters, and you're in. It's all personal to you. It's personal to me. That's why we're all here. But I think you got to work in Republican Senate. That's what stops all the gun bills, all of them. It stops them all there. And the mental health stuff, a lot of that is just, and you know, the irony of it is the mental health, as you know, is so bad in rural America. I mean, I got Garrett County. I mean, none of you guys are from Garrett, but I mean, you know, we don't have one full-time psychologist. We got zero. And so we got to get more mental health professionals, and we've put money in the approps for that, and it's driven to urban centers, super urban, which are lacking, in rural. But these rural are all Republican districts. So we got to talk to your Republican colleagues in the Senate that we've really got to beef up the support to convince people. I was with a doctor the other day, and he was telling me that they just built this whole wing for mental health down in Ocean City, whole wing, and they can't get anybody to staff it. I said, well, what's the deal? He says, the doctors look at it. We offer them a big salary. We reload, we pay for everything. Then their wives look at it and say, I don't want to live there. And so we got to figure out a ways to get them. We're trying this with Meritus Health in Washington County. We're putting in a school, a med school. And the idea there is the doctors, hims and hers, will move there for med school, maybe meet somebody that's local. I'm not kidding you, and stay. But every time they get people, they leave. And they go back to, they all want to be in the big city. And we can't get them in rural America. And I came from a rural background. I mean, my dad was a farmer. I get it. And so we really got to stress on our Republican colleagues the acute shortage of therapists, all of our healthcare workers, you know, peer-to-peer specialists, psychologists, psychiatrists. We are way, way behind. It's hard work, as you know, and the pay stinks. You know, one of my daughters is a therapist now, and it's just terrible pay. But you know what? It's great work. And you go home every day saying, difference. I don't do that every day. And so I think you got to work on them. But Republican Senate, you're talking to your Democrats. I would talk to your Democrats and say, why don't you pick a friend on the Republican side? Instead of just talking to each other, and which we do well, get a Republican. We got to reach out. We got to broaden the tent. And we got to bring them in the tent. Then we get stuff done. Next.
Okay, we've got time for 2 more questions. What are some unconventional ways constituents can influence their member of Congress to work on mental health policy?
Wow. Should have given me that one ahead of time. Unconventional. I think the only thing that's really unconventional is you can't just present them with the facts. You got to make them feel what you feel. You got to make them feel your tragedy, your experience, you know, your loss, and others that you know and love's loss. You know, stories, you know, that's what affects people. And when it's real up front. You know, I'm from Des Moines, and here's what happened with me and my family. And, you know, and then they kind of like, wow, that could happen to anybody. But you gotta break through and give them some real passion to break through that veneer of just politeness. Time for politeness, it's freaking gone. I mean, 48,000 dead. We want to be polite. We want to be a pretty pushy. That this is not acceptable. What are you doing, Mr. Representative? Why are you not on bills for this? Why are you not writing bills for this? You got to be there for us. Be there for something that matters for people, not just business and tax rates and all that BS. Be there what matters for people. One more.
Great. And we did just get a follow-up comment, which is that you can always call on our AFSP 74 chapters across the country when you need help as well.
Yeah, good. That's a good one.
And our last question, where do you get a chili cheese dog for $2?
Yeah. You know where that is? Cloakroom. There's one woman there. She's been there forever. And she makes barbecue on Wednesdays sometimes. But you can't count on it. You can hope, but you can't count. But you gotta meet people where they are is what it really means. And, you know, I would also maybe work with your chapter. District offices are all looking to do events. This is an idea for you. All looking to do events with their member. So like when their member's off, like I'm off this week for, 7 days. So I'm scheduled Ocean City to here, to Rockville, to Frederick, and then I'm going to Garrett County, then I'm back in Baltimore. And their members are the same kind of way. So they're all scheduled. So contact their district offices, Senate and House. But if you got a Senate Republican, that's the gold standard right there. That's where we got to find 10. We need 10. We'll probably end up maybe with 50, maybe 49 best case. But then we're going to need 10 or 11 Republicans, and we'll have the House, and we have the presidency, and we can pass a lot of good stuff. But we got to get 60, because my moaning about the filibuster, I hate the filibuster. I want to get rid of it, but it doesn't matter. It's not going to go away. So why waste too much time? Let's focus on what's real. I think talk to district directors and try and get them to come to various events that tie in with mental health, tie in with suicide, tie in with people struggling, addiction, all the crisis centers, things like that. Get in front of those district directors, and then also get a good look at their community project funding. I've worked on my community project funding all through my districts, and we're building a crisis center in Frederick. We're building a crisis center in Hagerstown. But, they can build crisis centers and things we need, or they can, fund God knows what. But this community project funding is a really good tool to distribute a lot of money to things that really need help. And if you ever have a question, your office, the district office will have a guide of how you go about it. This year's already left the station. That's done. It's in the bill, and Republicans have a good plan. They sliced all of ours. So we're getting 30%. We gave them 100% last year, but they said, well, that was last year. Now you're not in charge. So we're getting 30%, and they took out all earmarks from labor HHS. Guess what's in that? Addiction, mental health, education, 100% eliminated earmarks for that area. Why? Because 90% of them are Democrat. They decided they didn't want to fund that ratio. So they eliminated them completely. That's serious shit. I mean, that's not how I would operate. I would operate in a more magnanimous way, that we're working together. I look upon this deal as Team America, not Team R, Team D. We ought to be one damn team, Yeah. It's crazy. So get with those district offices, push them to do something. And then when you get that event, go back and push them for the next event and the next event. But if you get the member in your world, the more time he spends in our world, the more he or she will be with us. So we got to surround them with our issue, our mission, and make them mission driven. Thanks a lot. Bye-bye.
Thank you so much to Congressman Trone and the Mental Health and Substance Use Disorder Task Force for all their work to improve the lives of those struggling with their mental health and thoughts of suicide. Our final policy session for you today will focus on the 988 Suicide and Crisis Lifeline. We are pleased to have some experts joining us from our partner organizations, Jennifer Snow, National Director of Government Relations and Policy and Advocacy with NAMI, Megan Hott, Chief of Staff with the National Association of State Mental Health Program Directors, leading us off the session, we share remarks from U.S. Senator Chris Van Hollen of Maryland.
Hi, I'm Chris Van Hollen, and I'm proud to represent Maryland in the United States Senate. And I'm especially honored to join all of you for the 14th Annual Advocacy Forum of the American Foundation for Suicide Prevention. I want to begin by thanking all of you for over 3 decades of dedicated life-saving work. Since 1987, the AFSP has funded scientific research, organized educational initiatives, and advocated for groundbreaking changes to public policy, which have saved countless lives and supported so many families who have lost loved ones to suicide and other mental health crises. I am proud to stand shoulder to shoulder with you as we work to ensure that equitable and accessible crisis response services are available across our country. This past July, we reached an important milestone in our efforts, the launch of the 988 Crisis Response Line. This universal 3-digit telephone number serves as a critical lifeline for individuals in crisis and will ensure that people know how to get the care they need when they need it. 988 is just as easy to remember and easy to dial as 911 and has been a crucial step in our mission to treat mental health with the same seriousness and urgency as other emergency health concerns. Already, the 988 Suicide and Crisis Lifeline has streamlined access to responsive mental health care for people throughout our country. In the first 6 months following its launch, the Lifeline connected more than 2.1 million calls, texts, and chat messages from those in need to trained mental health crisis counselors. I was very proud to co-sponsor the 2020 legislation that designated 988 as the Universal Suicide Prevention and Mental Health Crisis Lifeline. And as a member of the Senate Appropriations Committee, I was proud to help secure additional federal funding for the 988 Suicide and Crisis Lifeline call center network and related behavioral health crisis services, including over $500 million in the fiscal year 2023 appropriations bill. These funds are helping ensure an efficient and effective transition to the new 988 designation to get this hotline up and running. In my own state of Maryland, our 8 suicide prevention and crisis call centers are successfully using the new 988 number to support Marylanders in crisis. This was, of course, an important step, but we can and must do more to tackle the ongoing mental health crises in our country. As we continue to deal with the after effects of the COVID-19 pandemic, including a concerning rise in the national suicide rate, the crisis has taken on a new level of urgency. We must take bold action to find comprehensive and innovative ways to destigmatize those in crisis and treat this epidemic first and foremost as a public health concern. The Community-Based Response Act, which I introduced last Congress with my former colleague, Congresswoman Karen Bass, would help communities establish emergency response alternatives to law enforcement involvement in situations regarding mental health or behavioral issues. Far too often, the involvement of law enforcement can escalate the danger of a mental health crisis and sometimes lead to tragedy. Like the 988 Crisis Lifeline, this legislation would help communities find accessible ways to support individuals experiencing a mental health crisis instead of alienating them or potentially unintentionally putting them in harm's way. I was proud to have AFSP's support in our effort to push this legislation. It's in that spirit I would like to end where I began, with gratitude for your fearless advocacy, life-saving work, and true partnership in addressing our nation's mental health crisis with compassion and care. Thank you for all you do, and I look forward to continuing to work with all of you in our shared mission. Take care.
So, Megan, I am so pleased to ask you a few questions. So the first one, tell me more about the National Association of State Mental Health Program Directors, and why is crisis care so important to those state mental health commissioners?
Well, first, I just want to say how inspired I am by all of you. You all are going to have a great day tomorrow. You're going to have a great impact, and 988 and crisis care needs folks like you. So thank you for being here. The National Association of State Mental Health Program Directors represents all the states, as well as the Pacific jurisdictions and the District of Columbia. and territories. And we have a state mental health commissioner in every state. And that's our main member. And then we also represent their deputies. So why is crisis care so important? Well, state mental health directors have worked very hard to implement 988 in their states. And all the states are structured very differently. There are county-based, there are statewide services, not that many, but our state mental health directors are primarily funders. They contract out services. They are the ones that provide state funding to, many of them, to the crisis centers themselves. So state mental health directors are very key to 988. They're working hard to get the word out and the timing of that word out, right? So it's the marketing is very important because you want the system to work. And you want the system to work before people call. So you don't want to get the word out before you know it's working. We know that it's working, and that's really, really good. You've heard the statistics, so many calls, so many texts. The response rates are going great, way better, astronomically better in just 1 year of the launch. The launch was last July, as the senator noted. So much work has been done. There's so much vision. Beyond 988, when somebody calls, what if they need more help? So you want to build out the crisis system continuum. I can't emphasize that enough. You heard my pause, right? Crisis services continuum, because as the senator was talking, you don't want a police response to somebody calling 988. In fact, the whole point of 988 is to divert from jails, divert people from emergency rooms so that they get the treatment response they need. To have that treatment response, many of the calls are resolved by calling 988. Thank goodness. I mean, if I had had 988 when I was a teenager, my life would be, I would have felt so supported, right? And if the school had said it, if my parents had said it, if my friends had called it and there was the word out that 988 was helpful, how, can you imagine that? You know what that really feels like? But then what if your loved one or me or anybody needed more help? The next step would be a mobile crisis team. That mobile crisis team should include a peer support specialist, somebody who the person in crisis can relate to. There are many models. NASHBA does not have a position on what that mobile crisis team exactly should look like, but I will say if law enforcement is involved, it should be very relatable. There shouldn't be a police car in the driveway. There shouldn't be, the police officer shouldn't be in uniform necessarily. It should be very relatable, very helpful, and that mobile crisis team should have a clear lead, preferably the mental health provider. So, and there should be more than one person responding. We hope for 2 or more people responding. So the many models across the country that work for those communities. So what if somebody needs more than mobile crisis? We want crisis receiving, crisis stabilization units. We call it maybe a 72-hour, 48 to 72-hour model. And that's where somebody can get some more intensive help. But the idea is that there's another step that that person then goes beyond that with support, follow-up, a treatment response. So why do state mental health directors care so much about this? Because it helps the system, it saves lives, it keeps law enforcement out of where law enforcement can do their jobs rather than deal with mental health crisis. So.
Thank you. Let's follow up a little bit on that. So what would you consider the priorities for the state mental health directors, program directors, with the implementation of 988 and the development of the crisis care continuum? And what are some of the biggest challenges? So priorities and challenges.
Okay. Yeah, so the priorities are to maintain the great work they've already done in implementing 988 and to continue to figure out the funding. One of the most difficult things is that sustainability of funding. There's been a lot of one-time funding. There are a lot of restrictions around that. The mental health block grant specifically has one set aside for crisis services. But the mental health block grant is, for some states, just 1% of their budget. Some, it's 5% of their budget. It really varies. But the point is, it's small. It's flexible. It's very important, but it's small. So the mental health block grant cannot be the complete funding source. There needs to be Medicaid. There needs to be, other sources of funding, state general funds. And states have various ways of addressing those funding issues. And it depends on whether a Medicaid expansion state or not in a Medicaid expansion state, what the priorities are for that state. When you look at challenges, funding is a major piece. So, of course, we're delighted that you're going to have this visit tomorrow. How important that is. And to keep it on the radar of Congress, of 988 and building out the crisis services system. So we always talk about it, 988 and crisis services, 988 and crisis services. It's like they go together. Some of the challenges have been how to build out that crisis service system, mobile crisis teams, staffing models, going 24/7 in terms of mobile crisis teams. How do you do that with a rural area? There are a lot of innovations in terms of talking about using technology. Oklahoma has a great iPad program that they use for, basically they use it to have a police officer have contact with the person in crisis, and the police officers themselves actually use it as well for their own difficulties. So, but it makes it very easy to use that technology piece to connect to a crisis service provider. Several other states are doing something similar. So I don't want to just only give credit to Oklahoma. There are several others, but Oklahoma is doing an outstanding job that can be looked at as a great example. So getting that outreach to places that are difficult. I would also say getting the word out about 988 in terms of different populations, LGBTQ, deaf and hard of hearing, what are the needs of specific populations? Those are challenges. But states are doing a great job thinking through how to do solutions. And I will say the Substance Abuse and Mental Health Services Administration is doing an outstanding job in their leadership. So just really thrilled that this is at the top of their radar, the top of their efforts to build out that crisis services continuum.
Thank you so much. I know, Megan, we spoke before and we were talking about workforce and that being a really driving or crisis. What do you see as the greatest challenges to the mental health workforce crisis, and how can those be addressed? It's a big question.
I have all the answers to this one. No, I don't. So NASHBID really does look at this very carefully. And actually we have a NASHBID behavioral health workforce resource guide that we just put out. It doesn't only address crisis services, but we really look at workforce from a framework. And we asked permission from the National Conference of State Legislatures to use their framework that they came up with to apply it to what's going on with our workforce challenges. Now, what's so cool about that is using a framework really allows people to have a common language and a common way of thinking about workforce. historically, it was, well, we have this system. And so within this system, we have this many vacancies of psychiatrists, we have this many vacancies of psychologists, this many vacancies of nurses, and this many vacancies of, keep naming it. Well, what if we change the system? Our system is changing because of 988 and building out the crisis services continuum. So when you change the system, then what workforce do you need? And that is a whole new way of looking at it. It's a paradigm shift, and it gets everybody thinking differently and more solution focused. And the system defines what we need, and the people defined what we need. So that has been, it's more about the approach than the answer at this point. But there are state examples within that Behavioral Health Workforce Resource Guide that I encourage you to look at. The Workforce Resource Guide is actually not on our website at this point because we're always updating it. It's a working document, but please feel free to email me, and I'm happy to provide it to you, Laura, if you want to send it out to everybody. But it does get updated on a quarterly basis. The other piece that I think is really important for workforce is to have peer support specialists. Now, integrating peers all across the system, it's not the only answer. I don't want to put the workforce burden on peers. And sometimes when we talk about integrating peers, it can sound like that. Integrating peers means there's somebody relatable all across the system that comes in and helps. People with lived experience can do a lot of jobs. They can go and get a social work degree. They can do, whatever. But I'm talking about people that sit with somebody in crisis and help them understand, I've been there too. I got through it. You can too. So I'm being very specific about that role. The other thing is expanding the roles of some of the professions. You don't necessarily need really high-level professionals to do some of the roles. So looking at how the roles can change and kind of intersect more is also helpful. And that depends on the community, the state structure, licensing. But some of those flexibilities happened during COVID, for example, where there was a lot of reciprocity, telehealth flexibilities that should continue. There is an important piece of having in-person care, but telehealth can definitely play a great role in workforce support.
Great, thank you. Before I turn it over to Jen to provide an overview of 988 and building out the crisis continuum, and Emily doing a deeper dive, any last remarks or resources that you want to share from the NASHPID website?
Thank you, Laura. That was perfect. Okay. So the NASHPID website does have great resources, and I encourage you to look at those. There's frequently asked questions about 988, model bills that we encourage. So take a look at those. We also do 10 papers a year that focus on crisis services and get very specific about different aspects of crisis services and 988. How to work with law enforcement, for example, or interoperability between 988 and 911. So they're a little bit more in the weeds than you probably want, but the resources are there. Thanks.
Thank you so much. And what you'll hear from our partners from NASHPID to us, AFSP and NAMI, is a mental health crisis deserves a mental health response. I'm going to turn it over to Jen and Emily. Thank you so much to continue the conversation on 998. And thank you to Megan. They'll be available for questions as well. You can go up to the side.
Hello, good afternoon, everyone. Great to see you all. I see that my slides are up and I just press this button. Wonderful. Really great to be with you all today. I'm Jennifer Snow. I'm National Director of Government Relations and Policy at the National Alliance on Mental Illness. I'm sure most all of you know your local NAMI, but if you don't, please get to know them. They certainly work so well in many instances with their AFSP partners on the ground, and I hope your instance has been a positive one. So we're going to talk a little bit about 988. Now, given we've mentioned it a lot, Representative Trone did, you heard a bunch from Megan, but we're going to kind of go back to basics just because I imagine that there might be someone in the audience who wasn't able to follow everything that was discussed so far. So bear with me for those of you who know all of this already. It might seem like a novel overview, but just at the very basics, what is 988? It is the new number, nationwide availability in all 50 states, 5 territories, for people in mental health, suicide, and substance abuse crisis. It became available nationwide on July 16th of last year. It is a federally created resource, but it is really implemented locally at states, tribal, territorial, and the local government level. It operates through the National Suicide Prevention Lifeline, which was available back in 2005. And it's made up of a network of about 200 local call centers. It is free, confidential. It is available 24/7, 365 days a year on the phone, through text, or through a computer interface. So as we said, 988 is an entry point to a reimagined crisis response system. That is our goal in ensuring that everyone in a mental health crisis can get a mental health response. But in order to have that reimagined crisis response system, we need more than just a number. We need a full continuum of crisis response services, which we heard Megan talk about. And you'll see it here represented as 3 pillars. This is what SAMHSA identified as best practice crisis response continuum. The first is that number. That 988 is someone to talk to. For most people, estimates somewhere between 80 and 90%, most people, that's all that they need to de-escalate the situation or provide connections to further care. But some people need more. That's where the second pillar comes in, mobile crisis response, or someone to respond. Again, for most people who need a mobile crisis response, they are able to de-escalate on the scene, and that's all that is needed. But for some people who need more, it's that third pillar of crisis stabilization or a safe place to go. We have this best practice. We know that 988 is the entry point, but we still have a lot of work to do to build out this crisis response system. So let's talk a little bit about data. You heard this alluded to so far, that in the year since, in the 10 months or so since 988 has been available, we have seen a dramatic increase in contacts to the Lifeline. A 41% increase year over year. So that amounts to almost 4 million contacts so far in the 10 months that's been available nationwide. And while that is a staggering enough increase, look at the increase for text. Over 1,000% increase in text when you look at it year over year. And this is somewhat a proxy for how young people reaching out to the Lifeline, because we know from data that that's the way young people like to communicate. Less picking up the phone, more using their thumbs to communicate via text. But another critical thing that I believe Representative Trone mentioned is that answer rate. You can see that last April, the answer rate was only about 75%. In this April, it was a 99% answer rate. And I'll be honest, this is what was keeping me up at night leading up to the launch of 988 is we're gonna have more people calling. Are they going to get a response? And thankfully, the answer is yes. All right, so let's go into some challenges and opportunities, depending on whether you look at the glass as half full or half empty. So again, building that crisis continuum, as I mentioned, those 3 pillars that are so critical to ensuring that every person can get what they need in a crisis. We know that the call centers, even though we got huge increases in federal dollars, they are still largely underfunded. I think that some are being held together with a little more than duct tape and Band-Aids and the benefit of the individuals who care so much and are there volunteering their time. We know that mobile crisis services are only available in certain areas, and crisis stabilization are even more limited. We have a far way to go to build out a true crisis response continuum in this country. Another challenge or opportunity is funding. So we've talked about it a little bit at the federal level. You heard Laurel mentioned we had a huge increase from FY22 to FY23, 5 times increase. That's enormous. However, the dynamic has changed in Congress, as Representative Trone had mentioned, and there is really right now a looking in the House to bringing those numbers back down to FY22 levels. That would be disastrous for 988. And I know that I saw that one of the asks that you all have for tomorrow is 836 million, which probably isn't enough truly to adequately fund what we need for 988, but you have to think about it in context of if we go back to the 22 numbers, we're talking about 100 million as opposed to 500 million. We knew that there's a set aside in the mental health block grant, but it is fairly small. There are Medicaid options to pay for mobile crisis response, but not all states have taken that up yet. So we've come a long way, but we still have a really far way to go when it comes to federal funding. When we look at state funding, we have only 5 states that have passed the 988 model legislation with fees. And I know my friend in Alaska here, Annie, you told me that there might be some states who have done things through executive branch orders, but we still have far to go when it comes to enacting a fee to help pay for those crisis response services at a local level. Awareness. So you'll see the picture that's on this slide. I don't know if you all are taking the metro at all, or if you're just going to be walking up to the hill. If you take the metro, you will spot signs about 988, which is wonderful to see getting the word out. More people are becoming aware of the service, as is evidenced by the increased calls that the Lifeline has received. But still, there has been no national public awareness campaign, and overall awareness about 988 remains pretty low. NAMI has done some polling. June of 2021, 80% had never heard of it. That only went down to 77% right before the launch of 988. We'll have some new data coming out soon, but it's fair to say that many people are still unaware of 988. Another challenge is geo-routing and geolocation. Now, I know just seeing from the tent cards at the table that many of you you're here in DC right now, which the local area code is 202, but I suspect that many of you do not have a cell phone that has a 202 number. If you were in a mental health or suicide crisis today and you called 988, you would get a call center based on the area code of your cell phone, which in and of itself isn't bad because you are getting a trained crisis counselor who could help you in that instance. However, if you needed mobile crisis response, you're in DC. And you're getting connected to a local call center back based on your area code. This really is far from ideal. We know we need the FCC to act in order to require the data to be transmitted to the appropriate call center so that people can connect it to local help. So if follow-up services are needed, they are able to effectuate that and not have to try to transfer you across the country to get you to help locally. Some other challenges, standards and training. Right now, those 200 local call centers, there are some required trainings and some suggested trainings. We would want to make sure that everyone is trained appropriately to respond to anyone who calls, whether that's mental health, suicide, substance abuse, whether it's an individual in crisis or a family member or a friend calling on their behalf. There's also interoperability, the connection between 911, which I know Nashville has done some great work on providing resources, because there are some instances where people call 911 where their issue might be more appropriately addressed by 988, but similarly, there might be people who call 988 where there truly is a law enforcement component where a 911 response is needed. There's also, we're in great need of having specialized services for at-risk populations. We heard Representative Trone mention that when it comes to LGBTQI+ populations. There's a pilot program now to try to address their needs specifically, but we recognize that there's a huge mental health need within that community and others as well. And right now we don't have the appropriate funds to be able to meet that. So now that I've been a Debbie Downer and I've talked about all of those problems or challenges or opportunities, I want to give you some hope going forward that NAMI and AFSP have been working together on this, and we are not about to stop. We have what is called Reimagine Crisis Response. It is a partnership of over 50 national organizations, some mental health, but some not related to mental health at all, who have come together under a united mission that we need to ensure that everyone in a mental health crisis receives a mental health response. Last week, we had an annual summit where we brought together policymakers as well as congressional representatives to talk about the issues going forward and what we were going to do to improve upon things. We also had a congressional reception. You can see here, look, there's Laurel, you can see Emily in the pictures, and a bunch of representatives and senators who received the first annual Crisis Response Champion Awards. The great news is we have bipartisan support in House and Senate to address these issues. We just need boots on the ground like you to go and remind folks of the need for that, particularly in the context of these challenging fiscal times, to make sure that they are prioritizing 988 and crisis response services when they come up with that budget. So with that, I think we're turning it over to conversation. And here's some resources that NAMI has created. We'll get you these slides if they're helpful, and thank you so much for the opportunity.
Let's get to my slides. Okay, so we've heard, first of all, from some amazing speakers, Megan and Jen and Laurel, who really gave us sort of a good thread, right, from Congressman Trone around challenges, but also so many opportunities, and then some of what's happening both at the federal level and the state. And I know we've also heard a couple of phrases thrown around like glass half full or Debbie Downer. I'm going to add one more, which is when it comes to funding or appropriations, it's good to be optimistic but realistic. And I think that really is important as we pick up on what Congressman Trone says and what Jen said about funding at the federal level, which is our third ask. Yes, it's a challenge up there on the Hill. Yes, this is not an easy ask, but the reason that we're making the ask is it's because it's critical, it's probably really not enough, and it's essential that we don't go back to FY22 levels. So this ask moves us away from what you heard earlier today from our other speakers, from Joanna's group and from Bill's group, from authorization bills. Those are the bills that, let's see here. I'm gonna get to that in a second, but those are the bills that say what Congress can do, but don't give the money for it. And we're moving into 988 funding or appropriations, which is all about the money, the goods, okay? So this is when the conversation gets a little trickier. So I just want to spend a few minutes before we do get into what the specific ask around 988 is going to be, to talk briefly about how 988 is funded. And I'm not going to spend a lot of time on this because we've already heard really a lot of key points around funding. And also I know that many of you are so intimately involved in 988 bills and advocacy at the state level. But just briefly, federal funding for 988, it goes to managing call centers, best practices, public messaging, partnership opportunities, technical assistance, and then at the state level and territory level, telecom fees can be used to fund 988 operations. But we do know that only 1 in 5 states have reported no dedicated suicide prevention funding. And we're about at soon to be 7 states that have enacted sustainable sources of 988 funds, with the latest being Oregon. So high five to Oregon out there. There's the table. Absolutely well deserved. So I'll also pause here because we are talking about the advocacy ask to just say that in your soapbox tool, you also have, if you open up the 988 resources page, you'll see both a map that Jen referenced from the Reimagine website of where these bills have been enacted or passed and been enacted, or where there's still waiting. But you'll also see a list of in-state answer rates. And this might not seem all that thrilling, but we talk a lot when we talk about advocacy on the Hill about storytelling, and you've heard a lot about bringing your own story as you're comfortable with into these meetings. But data helps too, and data can be threaded into those stories. And for the federal team, Bill and Joanna and myself, a lot of times when we're on the Hill, we get questions sometimes about how's my state doing? We also get bragging, folks who are bragging, did you know my state has like the 3rd, greatest response rate, things like that. So we provided that resource to you and recommend in your state meetings this afternoon that you take a look at that. If your state's doing really well, brag about it, and then use that as an opportunity for all of these future build-out work we need to do in crisis services and why further investment is needed. If your state has had challenges reaching, a good answer rate, use that as a starting off point as to why investment is urgently needed and why it's essential that the investment goes to your state. So I know probably some of you did not sign up for Authorization versus Appropriations 101 when you came to DC for the forum. And I know that this is less exciting about boots on the ground than the boots on the ground going to the Hill tomorrow. But what I'm hoping for in this section is to really orient you to what we're talking about when we're talking about funding, so you'll feel confident, prepared, and really get a sense of what the Hill staff that you're meeting with will be thinking when you come to them and talk about an appropriations request. So I already talked a bit about this, but just appropriations again, it's about providing money to be spent. So providing money to be spent on 988. Congress has specific rules and practices that govern the consideration of appropriations measures. This is referred to broadly as the congressional appropriations process. And the appropriations process generally handles the discretionary portion of the federal budget. So only important for you to know in that we are not talking about mandatory spending, which includes programs like Medicare and Social Security when we're talking about discretionary spending, which includes mental health programs and other programs. And appropriations bills are developed and considered by the House and Senate Appropriations Committee, as Laurel said, each year for the federal government's fiscal year, which begins October 1st. By the way, as a side note, a CR, we keep hearing these acronyms being thrown around. I know Congressman Trone threw out, we always end up with a CR. A CR is a continuing resolution. You may have heard this is the last minute sort of scrambling. Is the government going to shut down? Is it not going to shut down? Are they going to pass an omnibus bill? Another term that we're not going to get too much into today. Continuing resolution is when funding levels stay the same as the previous year, essentially because they couldn't get it together and pass a new appropriations package. So keep that in mind as well. Okay, I know the appropriations process can be complicated. We're here to make you confident with the basics. I'm gonna take a few minutes really quickly just to go through the basics. Again, you don't need to memorize this. You don't even really need to write it all down. It's just to give you kind of a flavor of where we are in this cycle. What are we talking about when we're talking about appropriations committees, passage, funding, etc. So Congressman Trone actually touched on a few of these. I'm glad he sort of readied you for this presentation. But the appropriations process typically starts with the submission of a budget by the president, which lays out the administration's priorities for federal agencies. This is essentially a blueprint. Sometimes you'll hear, depending on the politics between the president, the administration, and Congress, oh, this budget is dead on arrival, right? If the majority in Congress is different from the White House, you're gonna get a budget that's definitely not gonna see the numbers that are in that original blueprint. Congress then should pass a budget resolution that gives the 12 appropriations committees in the House and Senate the spending levels they need to fall under. And this year, as Congressman Trone also alluded to, hot topic was this debt limit suspension and budget deal. Lots of details fall within this Fiscal Responsibility Act that you don't need to know. But what is most important is that, yes, they agreed upon levels for fiscal year 2023, even though we're in currently fiscal year 2024, but that some members of the Republican Party are pushing for lower levels, those FY22 levels that, as Jen alluded to, would be around 100 million, which is nowhere near the 500 plus, nowhere near the 836 million, and really would be quite disastrous for 988 and crisis services. And the political dynamics in the House in particular are going to make things harder. That's just reality. We can be optimistic, and we absolutely are going up there tomorrow to advocate for that $836 million. We also are realistic that there are a lot of important discussions and that the political dynamics make things difficult. We may not get to the $836 million, but that's when you bring it back to your state and your story and your district about why that funding request is so important to you. And the Labor HHS Education Appropriations Bill, that's the one that funds SAMHSA, which includes 988 and crisis services, is the largest non-defense appropriations bill. That also means that it falls later in the appropriations process. So when we're looking at this timeline, 4 or 5 appropriations bills in the House have already been marked up. That means they've already gone through the committee process, numbers have been set. The Labor HHS bill, the one that 988 falls under, has not yet. In fact, it's expected to in the next couple of weeks, so your timing on the Hill could not be better. This is the time that members of Congress need to hear from you. And I know Congressman Trone also mentioned earmarks. These are also known as community project funding requests that will keep spending levels lower in the House overall. Now, the Senate dynamics are a little bit more favorable to higher spending levels. So we can expect we may see higher funding numbers overall in the Senate. And again, despite these dynamics, our ask remains strong for that $836 million. The House Appropriations Labor HHS Education Bill is the one that is considered by the Labor HHS Subcommittee. I put the ranking member and chair of each just to kind of give those states a little shout out. You can tell in Soapbox whether your member is an appropriator. If they are, great, that's fabulous because they're the ones on the front lines making these decisions about funding levels. But every single member of Congress is going to have their say when it comes to funding bills. So every visit you make over the next day is going to be important. Okay, so we're gonna dive a little bit deeper into the ask of what $836 million means for funding for the 988 Lifeline in fiscal year 2024. All right, we sort of went over this a little bit, so I'm gonna skip, but you can see those are the numbers laid out on the screen about the different final numbers. And of course, we are going with the $836 million. As you heard, I mean, SAMHSA estimates 9 million contacts will be made to 988 in a fiscal year 2024. This is an increase of 50% over the anticipated 6 million contacts for FY23. Melissa did a great job of incorporating some of those numbers into the skit you heard earlier today, and it's a really powerful message. You probably felt that as you were sitting listening as well. So what is the money going to be used for? What will it do? It's going to enhance local capacity through partnerships in behavioral health crisis response, support network operations, including centralized network functions, staffing for backup centers, call, text, chat, data infrastructure, training, quality improvement, evaluation, oversight. Funds are also going to be used to support those specialized services for LGBTQ and services for Spanish speakers, and for the 988 and Behavioral Health Crisis Coordination Office, which provides technical assistance and other services. The funding is also going to be used for public awareness with targeted 988 national messaging, which we saw on Jen's slide, for example, from the Metro, those beautiful 988 banners that are around to really increase public awareness, and also have specialized campaigns for different populations. And overall, full implementation and promotion of the 988 Lifeline, it's going to reduce healthcare spending and lessen the burden on emergency rooms and law enforcement with cost-effective intervention. I am now going to before we open it up to discussion and Q&A, just flag a few questions that you're probably thinking, or you might be afraid you might get on the Hill, to really talk through some of them now. We'll also have opportunities later today in your discussion, and you can always flag one of the Fed team members to go through some of this as well. Questions about funding levels, I think, was really well addressed by the skit earlier today. You know, that's just getting back to the, well, you know, 836 million, that's a lot of money. Melissa and Dave covered that so nicely. Yes, it's a lot of money. This is why the ask is so important. Really bring it back to your state and district. Questions about state answer rates. That's what I was alluding to earlier a little bit about, well, how's our state doing? Or the question that Dave took earlier as the pretend staffer, is this really making a difference? What's actually happening with the numbers? So have those numbers at the ready as well. That will help be prepared for those kinds of questions. Sometimes questions about privacy and law enforcement responses come up. I've got 2 minutes, but luckily we have predicted these questions and put together a hot sheet of kind of some of these harder questions, these sticky questions that you might get. That hot sheet is in your packet, and you can see and take a look at that for reference. What else? I have the specialized services. So I know I've already addressed a couple questions and folks coming up to us about LGBTQ, if there are questions that come up, or if your member of Congress maybe has been outspoken on LGBTQ issues, favorable or not so. When it comes to specialized services, if those things specifically are asked of you, for the LGBTQ pilot, that's already operational. The pilot is already ongoing. So while funding would go to support that program, it's already being run through SAMHSA. So there will be building out of that program along with other specialized services as well. So just to wrap up, and we're gonna, as a Fed team, go through these talking points, but these are the same talking points that you have in your packets as well. This is just the summary. They're based around the numbers of calls and connections that Lifeline has received, the importance of building out the crisis system, and the urgent need for funding. And with that, we'll open it up for discussion and questions. Thank you so much.
Okay, we've had a few questions come in already, and I will give you the first one. How can crisis services or 988 be implemented in schools or with youth?
We just answered. Can I answer? Okay. That is such a great question. And in fact, I had just written down children's crisis services to bring to light that children and adolescents need a different response than adults. And part of that, 836 million, when you look at building out the crisis services continuum, and Laurel asked me, what are some of the challenges? It's like I could talk a lot about building out a children's crisis services system. The mobile crisis response is very different in terms of bringing in the family, ensuring that the child can be at home if it's safe. And so it's different. It's traumatic for a child to leave their home and go to a hospital or somewhere else. So we want to try to keep them connected to their family. So when you talk about doing a crisis response for schools, you would definitely want to build partnerships between the State Mental Health Authority as well as the Department of Education, among others. But it's different in every state, depending on how they're structured. But those partnerships and those relationships are critical. Anything you guys want to add?
Okay, thank you. Next question is, how do we answer the question that 988 funding is the responsibility of each state? That when 988 passed, the federal government only planned to fund in the short term, and then the goal was for states to take that over.
Yeah, no, that's a great question. And I think you can imagine that certain members might have more of an incentive to ask that question than others, of kind of punt it to, not my problem, it's the state's problem. Whereas I think the appropriate response is to remind that it was always envisioned to have a braided funding stream. I don't think anyone that was part of the original 988 kind of vision and the Designation Act ever looked at this as a situation where the feds are going to start it and then it's going to move to the states. It was always conceived as there was going to be a combination of federal, state, and local funds braided together to get the appropriate response that we need. I think the challenge is that braiding together funding streams are not easy. And, certainly it makes our lives all the more challenges because we have to advocate at the federal level and then at the state level and then at the local level. But I think that, politely pushing back on that notion is probably the best way. Or I'm looking at Emily to see if she has any different recommendations.
No, absolutely. And I think the urgency of the issue also informs the response, which is that at this point in time, our ask is focused on the role of Congress in appropriating funds to the states, and the states desperately need it. Only 6, soon to be 7 states have enacted those 988 fee bills, which means most of them, how many is that? Most of them have not enacted those bills. And the reality is that Congress did sign up for a responsibility here. And, it's not about placing blame to any degree, but it really is bringing it back to the appropriations process has a magical opportunity to provide funding that's really urgently needed. And that's why you're making that ask.
And as a follow-up to that, who is actually paying the 988 fees in those 6 states that have passed it already?
So I live in Virginia, and if I go to my cell phone bill, which I know is so much fun to do, right? Like those, I mean, who looks at their cell phone bill every month? But if I looked at it, I am actually paying now on my cell phone line every month a 988 service charge. And that's something that is the ideal model language for the 988 service fees. And when people, the polling that we have done on this issue finds that, people, when you talk about, would you want to pay a fee to ensure that people get a mental health response? The number of people, the percentage of people who answer yes goes up dramatically when you tell them, do you know that you currently pay a fee every month for 911 service? So again, if you're looking at your phone bill right now, you pay a fee every month for 911 services. A lot of people don't know that, and because it's not fun to look through your cell phone bill, and that typically will reframe the conversation to, oh, if I'm already paying something for 911, it makes sense to be paying something for 988 as well.
Jen, I love that because it's a parity issue, right? That mental health be equal to health. And so, yeah. The other thing, our experience at NASHBIT has been that the word fee is perceived as tax. So you go in with the lens of what is the climate in that state related to fees, subtitled tax in their minds, versus the parity issue of 911 is already being billed, so mental health should be equal to that.
Thank you. We've had a couple of questions come in that are specifically asking about geolocation, confidentiality. I know we at AFSP have heard a lot of questions about this over the last several months too. So geolocation being a concern for many callers, specifically youth have been voicing concern about this. Can you guys get into that a little bit more? And then how should we be responding to questions about that tomorrow as well?
I can start. So the slide that I showed where, basically it had a caller in California that's getting connected to North Carolina. That is my sister-in-law who is currently living in California and had a call crisis line. She got connected to one in North Carolina where her cell phone is. When we talk about geolocation, it really is two separate issues. It is geolocation and geo-routing. Geolocation is the more fine data of exactly where you are calling from, where your cell phone is or where your landline is. Geo-routing has to do with getting you to the closest crisis call center as opposed to going back to the area code of your cell phone. The geo-routing is really what we are focused on in terms of what needs to change. And I think we have not heard any pushback from any community that geo-routing is something that causes people anxiety, because people want to be connected to local health. The issue gets more sticky when you talk about that true geolocation, those finer data points about exactly where you are. In some ways, I look at that as a huge problem that we need to address and have conversations about how do we make it appropriate that if someone is in a true crisis where they need a response for life-saving purposes, that the call center is able to provide that, but not jeopardize confidentiality, not jeopardize, not make people feel uncomfortable such that they don't want to call the center, or call the 988 number and get connected to a center. But in some ways, we are so far from that right now. We're just trying to get people connected to the call center that is in their state. So in some ways, I look at it, that is a critical problem, but that is not a problem for today, because we just at a basic level are not even getting people connected to where they are physically located.
Perfect. Yeah, and just to flag also, our tough questions sheet in your packet includes a question specifically related to privacy. So take a look at that. I also think it's an opportunity, right, when we have these challenging topics to admit that they're challenging. We talked earlier today that it's okay to say you don't know, that you'll follow up, but also to admit that this conversation is not done yet, that you as advocates are in those offices really to begin a conversation. And as these sticky issues continue to kind of play out, you want to be at the table with your member of Congress, providing your input and feedback and connecting it back to the district and the state. So to really offer to continue to be a guide. You're not going to have all the answers or all the solutions when you go in tomorrow. And as Jen so eloquently put it, like there are two separate issues, and one is admittedly challenging and sticky, and you're willing to kind of help work that through in your capability.
What they said. That's great. Yeah.
The next question is, where can we find out if our state or city or county has mobile crisis units or crisis stabilization centers?
The data is actually pretty new. We're working on that. The NASHBID Research Institute, which is separate from NASHBID but collects data on states voluntarily, is looking at where the mobile crisis teams are. In fact, we, NASHBID and NRI are doing state peer-to-peer learning sessions on mobile crisis teams. There's a series of 4 that addresses workforce and state staffing or staffing models for 24/7 coverage. So knowing where those are, we're actually sometimes just asking a state, you know, what do you have right now? There's such an emphasis on building out 988 and ensuring that 988 has good answer rates, including chat and text. So by the way, that federal funding, you know, what is it used for? Building out that chat and text is extremely important. And the other thing, I'm going off on a little tangent here because I had some thought on the federal funding piece, how important it is to have federal leadership around the call centers and around standards and evaluation and data. That is so important to have an understanding so we can move forward and improve the system. So I just want to bring that in, but knowing exactly where all the mobile crisis teams are is really more of a local question, I think. So, yeah.
Megan, I think that's said beautifully. Like, I would love to have a resource where I could send you to say, go here, and it'll tell you what's available in your region. We're just not there yet. I know that we at NAMI have had family members who have reached out and are trying to think about their loved one. If their loved one is in crisis, are they going to use this 988 number? And part of that is trying to understand, well, what is mobile crisis available in our regions? So we have even given the guidance of start calling your local, whether you go to the state usually can help you, but even calling your local, walking down to your local police department, trying to understand what will happen if I call 988. Are they connected to you guys? Are you going to dispatch somebody who has maybe perhaps in an ideal situation, if it's a law enforcement response, it's someone who's been trained in CIT. But it is a hard question to answer, and there's not a good answer right now in terms of figuring out if and where your mobile crisis team might be available in your region.
And to add to that, I think when you go in tomorrow, the biggest meta message is it needs building out. Nobody has it all done, all right. So all you need to know is it needs to happen. That's the main thing. So there isn't one state that has all of this figured out. They have pockets of excellence. There's some really good work statewide, but every state is on its journey.
Thank you. We have time for just a couple more questions. What has the efficacy of suicide prevention hotlines been shown to be at actually preventing suicide? And has that efficacy increased with the new number? What do we know about, how well this is working?
Jen mentioned actually in her presentation, and this is what the data says from SAMHSA as well, is that I believe it's about 80 to 85% of the calls are resolved on the call. That's a really big deal. The folks that are working these call centers are trained. They are compassionate. I've met leaders of these crisis call centers that I want them to be my best friend. I mean, they are really wonderful. Such a safe space, just absolutely just such a safe space. And so the point is most of the calls are resolved. I think that's huge. So yeah, do you have anything to add on that?
And I think the only thing to say is that we are in many ways, like, this is a once in a lifetime opportunity to reimagine the way we respond to people in crisis. So I feel like we are providing graduate students and researchers just a prime opportunity to really look at this as it's being implemented. What are we going to know about efficacy rates? Are they going to increase with kind of a more formalization of an expanded functionality of the existing lifeline? So I think there's going to be a lot more data to come, but recognizing that we really are only 10, 11 months into nationwide availability.
All right, and to close us out, is there a specified allocation outlined for improved access for persons with disabilities? So for example, for those who are visually or hearing impaired.
So not a specific number, but yes, in terms of building out those programs, including TTY and other services for the deaf and hard of hearing. This is all part of the $836 million ask, along with other specialized services. But thank you so much for whoever brought that question up, because that's a really important aspect of all of this as well.
Yeah, if I can add the piece about deaf and hard of hearing, at NASHBIT, I lead that issue. It's very close to my heart. What we're trying to do is really have video phone services for people who are deaf and hard of hearing, that people who are deaf and hard of hearing and use American Sign Language as their primary language need a video phone, and having trained crisis counselors that are ASL fluent work with that person. Having video relay services that then for an interpreter that doesn't understand crisis, when somebody is deaf and they know ASL, what they do is they call a video relay service. That video relay service then calls the entity that individual wants to contact. Can you imagine if one of those interpreters who's somewhere in the country, different standards on understanding interpretation, then tries to call a crisis center, and they're having to interpret crisis. And on top of it, they don't know where they're located, the name, there's finger spelling, there are different signs for different regions, different accents, different idioms. So the point is having that national center that would be a video phone services is what we're going for. And there's an RFP for that now. We're really thrilled.
Well, thank you so much for the great questions. And thank you to Jennifer, Megan, and Emily for this really productive and informative session on 988. Thank you very much. Thank you, Emily, Jennifer, and Megan, for that informative session. Now, to close out our policy sessions today, we have a few final remarks to share with you from the chair of AFSP's National Public Policy Council, Dr. David Jobes, followed by U.S. Congressman Seth Moulton of Massachusetts and U.S. Congresswoman Grace Napolitano of California.
Hello, everybody. I'm Dr. Dave Jobes, Chair of the AFSP Public Policy Council. And on behalf of all the National Public Policy Council members, I personally want to thank you for being an advocate for suicide prevention and joining in this year's virtual advocacy forum. I can't emphasize enough how important the role is that each of you play in making a positive change for suicide prevention and mental health policy at the federal, state, and local level. I hope that you will join us today in contacting your members of Congress in support of our policy asks that we know can help save lives and decrease suffering. Suicide prevention programming and resources for the veterans community, funding for 988 crisis line and crisis services, and last but not least is a focus on youth at risk for suicide who are struggling. Together, we have the power to save lives, but only if you visit the AFSP Action Center and take 2 minutes to contact your members of Congress. The Public Policy Office here in Washington makes it very easy with a pre-programmed message that you have the option to customize with your connection to this particular cause. I hope you'll join me in this important cause, and we thank you again for your support of AFSP's mission to save lives and bring hope to those affected by suicide. Thank you.
Hi, I'm Congressman Seth Moulton, and it's an honor to be with you this evening, even though I can't be there in person. A few years ago, when I decided to share my story of dealing with mental health, specifically dealing with post-traumatic stress after 4 tours in the Marine Infantry in Iraq, I didn't know if it might end my political career the next day. I became the first sitting member of Congress to actively talk about my personal mental health story. And rather than end my career, it actually launched me on a crusade. I released a 3-part plan to help improve mental health in America. The first part was establishing a 3-digit national hotline, and I'm so proud that I was able to pass that bipartisan bill with a fellow veteran, Representative Chris Stewart of Utah, a few years ago. And it was, of course, implemented this past July. The second part was improving mental health care for our active duty military and our veterans, not only because we know that they deserve it and they've earned it, but also because it sets a great example for everybody else. And I'm delighted to tell you that we've made great progress over several years with different provisions put in the defense bill every year. The third piece is to truly end the stigma of mental health across America by making it as routine to get an annual mental health exam as it is to get an annual physical. Now, this will entail a lot more work. It's a lot more resources. The idea to get everybody, every kid across the country with an annual mental health exam. But I'm delighted to tell you that we are working hard on that, and we're not going to stop working until we get there. I've always said that there's 2 fundamental issues we're trying to address with mental health today. One is access to care, so people know where to turn when they need it. But the second is ending the stigma so that people are willing to ask for help when they need it. I'm delighted to tell you that with 988, it's really done both. I knew it would improve access to care. What I didn't expect was how much of an impact it would have on the stigma. People are just talking about it. People are using the service. They're having those conversations around the dinner table with friends and family that just were too difficult to bring up before 988 brought mental health into more regular conversation across the country. The statistics, of course, are amazing. Calls are up 50% since the hotline went live, and texts, which of course are a proxy for youth mental health, are up 1,445%. There are thousands of American lives we're saving every single month because we're able to use this number and they know that it exists. But of course, those numbers also represent the true depths, the true breadth of this problem. So thank you for all that you do to address mental health in America. And I look forward to continuing to be your partner in the years to come.
Hello, I'm Congresswoman Grace Napolitano. Thank you, American Foundation for Suicide Prevention, for inviting me to speak and for your continued and necessary work to shed light on suicide, one of the leading causes of death. I proudly represent California's 31st District and co-chair the bipartisan Congressional Mental Health Caucus with my colleague, Republican Chris Stewart of Utah. The caucus is 101 members strong and growing, and works to educate members and staff on this critically important topic by disseminating mental health news clips, sharing relevant legislation, and holding briefings with mental health stakeholders. We will continue to fight for increased resources for suicide education and prevention, including 988. The COVID-19 pandemic has upended our lives and added additional stressors that have significantly strained our mental health and well-being. We continue to see a rise in reports of loneliness, stress, anxiety, and depression, and most of all, suicidal behavior. Suicide doesn't discriminate based on age, zip code, or socioeconomic status. It can affect us all, and we must work together to support those in need. We must share resources, warning signs, and symptoms, and stress that it is always okay to seek help. May Mental Health Awareness Month has just passed, and September Suicide Prevention Awareness is fast approaching. We must continue to discuss these topics year-round. Please get involved, help stamp out suicide. We have come a long way in making mental health a priority, but still remains very underfunded very misunderstood and still affects many in the country. We must also keep in mind that stigma and other cultural tendencies can prevent our loved ones from being open and honest about what troubles them. It is important that we educate our communities on mental health by raising public awareness, helping others in crisis, and changing the conversation around it. So every month, I encourage all to get involved, educate yourself, and share resources with friends and family. If you see someone that's fallen on hard times, help them out if needed, and then refer them to mental health services. Together, we continue to build a movement, eventually live in a world where there is no stigma.
Thank you, Dr. Jobs, Congressman Moulton, and Congresswoman Napolitano for your fantastic remarks and continued support to save lives. Thank you once again to all of our viewers for joining us throughout today's program. A special final thank you to all of our members of Congress that supported us with remarks in order of appearance: Congressman Don Beyer of Virginia, Congressman Chris Stewart of Utah, Senator John Tester of Montana, Congressman Mike Lawler of New York, Senator Chris Van Hollen of Maryland, Congressman David Trone of Maryland, Congressman Seth Moulton of Massachusetts, and Congresswoman Grace Napolitano of California, as well as our agency partners, Dr. Tamara Campbell, Executive Director of the U.S. Veterans Health Administration, Office of Mental Health and Suicide Prevention, and Brandon J. Johnson, Public Health Advisor for the Substance Abuse and Mental Health Services Administration, SAMHSA, at the U.S. Department of Health and Human Services. Before you close your computer today, please visit the AFSP Action Center and take 5 minutes to contact your members of Congress. We need your help in urging their support for suicide prevention for the veterans community, 988 and crisis services, and suicide prevention for youth and young adults. Thank you for using your voice and helping to achieve AFSP's mission to save lives and bring hope to those affected by suicide.
Pass the ketchup. Dad, are you okay?
Oh, yeah, just stressed out.
Oh, and the melody is sounding so much better. I can play it for you. Wait, where's your guitar?
I gave it to your cousin.
What? That guitar's like your favorite thing.
I don't need it anymore.
Oh, and I saw Henry today. Says he hasn't seen you around.
Oh,
Maybe you should give him a call.
I will.
I won't. You said you go.
Have more fun with your friends.
I want you there.
I'm tired. Some days are just better than others.
I think you should go talk to someone.
It's not that easy.
Dad, I can tell that you're hurting, but we can't keep pretending like everything's fine.
I know. I'm sorry.
Have you been thinking about suicide? You can talk to me, Dad.
It's been a tough couple of months.